Welcome to the first QFR of 2026. Neither rain, sleet, or snow will keep us from showing you a day's worth of PowerPoint presentations. If you have questions, you can either come back here and grab a note card and pencil, or you can submit them to the Ask the Secretary email address at askthesecretary@fssa.in.gov, and we will read the questions at the end of the presentation. A quick note, if I don't read your entire question or I don't read your question at all, it isn't personal. Some questions that have come in are way too long, or they are questions for the legislature. Others of you, the questions I might not be able to read your handwriting. So if you don't get your question read during or after the presentation, all questions will be answered in written form over the next week. First, we have Division of Family Resources.
I'm Sunshine Beam on the DFR director, and this is going to be the DFR report. Indiana Family and Social Services Administration Division of Family Resources is responsible for the accurate and timely delivery of SNAP benefits. DFR is also responsible for the accurate and timely determination of benefit programs such as this. DFR also manages programs to support refugees for training services for some SNAP and burial services for some medical. DFR has 102 local offices across the U.S. Here's a breakdown of 10 above. With 102 local offices, approximately 140,000 square feet of office space across the state. Is that better? This is the DFR staffing summary. See, in December of 25, we had 1,266 state staff and supported by 1,631 contractors. And in November of 2025, DFR was approved to add an additional 65 staff, and we are in the process of hiring those individuals. Here's our financial review outline, what we're going to cover today.
So, Sunshine, why would you be hiring more staff?
Why would I be hiring more staff? We hired 65 additional state staff to help address the SNAP error rate. We're first going to talk about our SNAP program, the Supplemental Nutrition Assistance Program. The Supplemental Nutritional Assistance Program provides food assistance to low-income individuals and families. It's a federal aid program that is administered by the USDA Food Nutrition Service. The distribution of benefits occurs at the state level. Benefits are provided on an electronic card that is used like a debit card and accepted at most grocery stores. The benefit is currently 100% federally funded. The administration costs are currently split 50%, with 50% being funded by the state. That changes in October of this year. It'd be 75-25, with 75% being to the state. Our current state fiscal year-to-date issuance, we have issued $667,984.109 in SNAP benefits, and we have issued benefits to approximately 3.4 million recipients. Collectively.
That 3 million number, it just represents the number of humans who have received a benefit. Obviously, there are
but
multiple.
They're not unique. Yes.
Yeah, that's correct.
And we can compare today's information to some historical information. And in this same time in SFY 2016, so 10 years ago, we had issued $550 million up to this point. And this year, 10 years later, we are at $667 million with less recipients. We have upcoming SNAP changes. We implemented, it's not on the slide, in January 1st, 2026, we implemented the Smart SNAP food restrictions. No individuals are no longer allowed to purchase candy and sugary drinks with their SNAP benefits, and that went into effect January 1st. DFR is currently working with retailers on that implementation. And as I previously mentioned, SNAP administration cost share increases to 75% effective 10/1 of 26. And our estimated fiscal impact for SFY 27 for 9 months is $37 million. And the annual estimated fiscal impact is $47 million. And then the state share of the SNAP benefits will be based on the SNAP payment error rate. The fiscal impact is somewhere between 71.5 million and 214.4 million. So effective 10/1 of 27 will be based on the error rate for 25 or 26. And then for reference, our error rate in FFY 24 was 9.27. So that would, if it was based on that, our state share would be 10% of the SNAP benefit.
Here's the fiscal for the SNAP admin program. As of the quarter ending, we are $991,878 underspend. And as of right now, we're projecting 1.9 million year in to be underspend in the program. A couple of factors on that is point one, we have some vacant positions that haven't been filled yet. For point three, one of our vendors, a conduit, currently they're running behind on submitting claims. Point seven, we have multiple vendors that are behind on submitting claims. And then you'll see us being over budget in the IoT. We have the funds to cover that. That was just due to one of the accounts that we usually don't. Historically, we didn't account for it in the QFR, but we did this year, which is for cost allocation, but we have the funds to cover that, so. For SNAP impact, for the quarter ending, we're showing a $1.5 million underspend, and we're projected 1.6 for the year end. And that's just, we have multiple vendors running behind on claims, submitting claims. We anticipate for them to get caught up on their billing. For EBT, the quarter ending, we are showing $135,731 overspend. For the year end, we are projecting $138,094 overspend. And that's just due to our data warehouse expenses are projected higher than what the current appropriation could handle. So we're going to have to find funds from either state earn or carry forward to cover that part.
Our TANF program, Temporary Assistance for Needy Families, provides cash assistance and supportive services to assist families with children under age 18 and pregnant women. The goal of the TANF program is to help individuals achieve or return to economic self-sufficiency. As a condition of eligibility for TANF, adult recipients are required to attend applicant job search orientation and complete applicant job search activities. Failure to complete those activities without good cause will result in a denial of the application for cash assistance. And that started in November of 2011.
Here's just TNF funding allocation for FFY 26, showing where the funds are going to outside of just the DFR program.
You can see in quarter two of SFY 26, the total TANF issuance was $6.2 million, with the majority with $6.2 million, with the majority of that, the majority of our TANF recipients, of course, being children.
For the TANF program, for the quarter ending, we are 5.1 underspend, and then we are projecting 3.9 million to be underspend by the year end. And if you look at 0.8 for our TANF cash assistance, that has been lower than we anticipated. And then for working families, we are just now starting to see expenses come in for that. This month, for December, we had 9.1 million Prior to the previous months, we didn't have any expenses there. So we anticipate for working families for that to start to ramp up.
Indiana's Impact Program, Indiana Manpower and Placement and Comprehensive Training Program aims to help participants achieve economic self-sufficiency through a combination of education, training, and employment supportive services. Services available include job skills training, assistance with resume writing, interview preparation, access to local job fairs, and employment opportunities. The Impact Program is available to SNAP and TANF recipients. See, in December, we served a total of 537 individuals across the SNAP and TANF program. And to our Medicaid program metrics, we currently have approximately 1.6 million recipients on Medicaid, and you can see the breakdown their enrollment by type. And then in December, we received 77,784 applications, and we completed 119,279 redeterminations. Indiana's Refugee Services provides assistance and services to refugees, asylees, certain Amerasian, Afghan, and Ukrainian immigrants, and Cuban Haitian entrants and victims of human trafficking. Indiana Refugee Services monitors program planning, provision of services, and provides technical assistance to ensure compliance with federal and state regulations governing the delivery of refugee assistance and services, including cash and medical assistance. All individuals served by the Indiana Refugee Services have legally entered the United States through the applicable federal program. This number has been steadily declining. The number of refugees we're serving on refugee medical assistance and refugee cash assistance. In December, we had 679 individuals on refugee medical assistance and then 347 individuals on refugee cash assistance.
For the refugee program, we are showing for the quarter ending 10.9 million underspend, and we're projecting 21.5 million underspend by the year end. And that's just due to the changes in the program. The program here identifies spending from cash and medical and supportive services. For the cash and medical, the budget was based off of last year, and working with OR1 and submitting our budget for this year has been drastically less than compared to last year. So we anticipate the program to be spending less than we did from the prior year.
DFR's burial assistance program was established by the state of Indiana to help with burial costs for those who are eligible for specific Medicaid categories. And then the maximum benefit is $1,200 for a funeral and $800 for a cemetery. And then those rates were last updated in 2013. And in December, we had 86 cemetery claims, 486 mortuary claims, for a total of 572 burial assistance claims.
For the burial program, for the quarter ending, we were $297,757 overspend, and we are forecasting an overspend of 1.9 million to the year end. And historically, we have been the appropriation hasn't been able to cover the expenses, so we've had to use carry forward funds or funds elsewhere to cover the shortfall here. For county admin, for the quarter ending, we are $1.9 million overspend, and we're projected to spend 22.9 overspend by the year end. Compared to July, we were forecasting a 37.3 million overspend compared to the 22.9. For point one, we had 65 additional staff added. For point three, two of our big vendors, Maximus and Knowledge Services, they've been underspending up to December on a monthly average. We anticipate them to start to ramp up on the claim submissions and the billing, but from the savings from the prior months, we're going to have a savings there. So our overspend is less compared to what we thought it originally was going to be in July. DFR admin for the quarter ending, we were $148,530 underspend, and we're projected to be underspend of $166,407. No major concerns in here. For IADS, right, for the quarter ending, we're $2 million underspend, and that was due just because the Deloitte is running behind on claim submissions. We anticipate them to get caught up on their billing. So year end, we're forecasting $28,142 to be underspend, but we're keeping an eye on 0.9 because we anticipate some of our postage to go up. And here's just a summary of all the programs that we just discussed from a financial standpoint. Here's just a chart of the major contracts that run through DFR.
Concludes my presentation. Did you have it? Are there any questions?
Could you comment just a little bit on the implementation of the work requirement for SNAP benefits?
Yes. Earlier this month, we implemented the changes that were in HR 1 that impacted the ABOD population, the able-bodied adults without dependents population that is part of the SNAP recipients. And the changes in HR 1 increased the age limit from 54 to 64. So now, or 59 to 64. So we're now including individuals who are 60, 64, who, if they're not exempt for another reason due to illness or something like that, they are mandatory ABODs. And then the dependent child used to be anyone who was under 18, and now it's 14. If your child is 14 and above, you're considered an ABOD. And so what that means is you're only eligible to receive SNAP benefits for 3 months in a 36-month period. You have to meet the ABOD work requirements, which is 20 hours, or you either have to be working 20 hours or you have to be participating in an activity.
People in Indiana were affected by that.
Well, it added an additional about 12,000 people to the ABOD rolls.
Okay, we have not received any question. Oh, we have one? Okay. Can you address, or can you elaborate on what the new staff are doing to help with to address the error rate? Are these QC folks? Are they new caseworkers?
No, they are not QC. They are not quality control staff. They will be eligibility workers. They will be state eligibility consultants and state eligibility managers, and they will be doing whatever it takes, right, to address the SNAP error rate. So they'll be working cases. They'll be doing case reviews. They'll be doing QA. They'll be working with staff. They'll be working with staff individually in regions to do. They are centrally located and they are managed by central office. So we will be deploying them and having them do whatever needs to be done.
Okay, thank you very much. OECOSL, the Office of Early Childhood and Out of School Learning's presentation will begin in 8 minutes. Okay, and thank you all for attending the quarterly financial review. Next, we have the Office of Early Childhood and Out of School Learning. Just a quick reminder as they come out and get set up. If you have questions, you can come back here and get a note card and pencil, or you can submit your question by email at askthesecretary@fssa.in.gov. Questions will be read at the beginning Also, just to nip this in the bud, we cannot answer questions about the legislature and what they may or may not do. Those questions should be directed to your legislators.
Thank you, Marcus. I am Adam Alson, the Director of the Office of Early Childhood and Out-of-School Learning, and this is the state fiscal year 2026 quarter 2 quarterly financial review. First off, I see here some new faces, and they've not been at these previously, and I appreciate you all coming and taking time out of your days to come and be a part of this. It is important. It's important for us as an office to be able to see you, interact with you either here and then afterwards, and everyone's busy, and I appreciate you taking the time out to come and be a part of this. So to start off, this is a broad overview of what we do as the Office of Early Childhood and Out-of-School Learning. So we have two main responsibilities. The first one is to regulate and license childcare programs throughout the state. So those fall into three broad categories: childcare centers, childcare ministries, and childcare homes. So we both do regulation around that, and we also do licensing, enforcement, things like that. The other thing that we do is we administer childcare funding for the state of Indiana. The major one is the Child Care Development Fund, or CCDF fund. We also administer state appropriated funds and other federal grants as directed. Our two main programs, and most of you probably know this, but we'll go through it real quick, is our CCDF voucher program for ages 0 to 13, and then the state-funded On My Way Pre-K voucher program for 4-year-olds. So since the last time that we had one of these in our space, late last year, the Administration of Children and Families and the federal government announced increased and heightened scrutiny around federal funding going from the federal government to states, and you know, we've communicated it to our customer base and our provider base already, but I wanted to give the opportunity to give an update on this. Currently, since that happened, OECOSL and FSSA as a whole has been in constant contact with federal administration and the Administration of Children and Families on CCDF draws and making sure that we're doing what we need to as a state and as an office to meet those heightened requirements. There's been no delays or anything from provider reimbursements. Since that, they continue as normal, and I will say we expect that to continue as well. And the third thing I'd like to say very, very briefly is that, you know, OECOSL, we do have, I believe we have strong internal controls and quality assurance processes, and we'll continue to work with the Administration of Children and Families on those issues, and also look to see internally how can we strengthen them even further. So, seen this chart before this is spending for childcare by state fiscal year. So this is, I'll be very brief on this, but effectively what we have here is we have a cliff, right? We have federal funding that came in over $1.2 billion through various COVID funds between the years of 2021 and 2024. Those went away. Those are gone. And, you know, what we have decreased funding over time as an office to administer for CCDF vouchers. And, you know, this is where we are currently. And, you know, in second half of last year, in September, we announced, in October, it executed the reduction in reimbursement rates. There's been a wait list for the CCDF voucher program since December of 2024. Here's some historical data, a couple graphs about where we are currently on these two things. From a voucher perspective, as we can see in the chart, it continues to go down dramatically. We're getting very close to a level that we have been in past before those COVID dollars came on. Current voucher, we'll get into the detail. There'll be more details about this later in the presentation. It's roughly at 44,500 children on the CCDF program currently. And on the total regulated childcare supply, we started sharing these numbers last last QFR, and will continue to do so in the future. We're at 175,000 total regulated childcare seats in the state of Indiana. A year-over-year increase of 2.7%. And as you can see from the graph on the left, it is starting to turn over. It is starting to turn over from a supply perspective. In the face of in this state fiscal year, in the face of a in a situation that we had that we had more obligations to kids and families that were existing on vouchers. We didn't have enough money to pay for them all. One thing that we have done as an office, we've seen this before, I've gone through this, but I want to reiterate the point that we as an office is also understand the value of CCDF vouchers and generally money going into the hands of childcare businesses, and then also the children and the families they serve through the CCDF program. And so from our perspective, we instituted and executed a pretty substantial cost cutting and cost containment strategy in this fiscal year. The highlighted ones are contracts that we've either amended, terminated, or not renewed for this state fiscal year. And with that is that we have an office over this state fiscal year have been able to save $30 million, right? And over the biennium, we project that number to be $75 million, and that money goes directly into fund additional CCDF vouchers, right? We have that money is going, instead of going to things that were of a lower priority, right? We as an office said, hey, highest priority is how can we do what we're supposed to do the best we can, which is fund CCDF vouchers. So as part of that and part of those strategies, we've also reduced contractor staffing by 2/3 and overall staffing by 50%. And we've been able to decrease the amount of our budget that goes to contracts and grants from 17% to 10%. And we've also been able to, and what that means is we've increased the percentage of our budget that goes to our voucher programs from 81% in state fiscal year 2025 to 88% in 2026. So looking at that, that's a bit of the past, right? And also current state, right? And the people, y'all that are here understand, and the people that are watching online, right, understand what the current state is. Now I want to shift gears and say, hey, what are we doing as an office? What are our goals in 2026 as an office? And I think the one constraint that, it's the one that's overarched discussions around this and our office since I began last year and will continue to do so in the office is funding, right? And what is that, right? And what is that going to look like? Our responsibility as an office is that we are the executive branch. We are an executor. We execute the wishes of the General Assembly and the governor. Our main initiative for calendar year 2026 continues to be fiscal responsibility and oversight for our two major funded programs, CCDF vouchers and On My Way pre-K program. There's a second thing that we're going to start working on, and I'm pretty excited to announce this today, is that late last year, the state of Indiana was awarded a federal PDG grant of $14.8 million. There's also a state match of $4.4 million to go along that. So there's $19.2 million grant that we, as a competitive grant from the federal government, we received it. We're very excited about about all the things that we're going to be able to do with that this year. Number one, and the main thing that we are looking to do right now, and as we execute this and get this set up, is the first thing we're going to do is what we're calling a referral slots pilot program. And what this is we look to develop a mechanism to connect providers, businesses, and CCDF eligible families and figure out, hey, how can we connect those two and then also provide funding effectively at the voucher level. So, we understand, and this will become clear in some of, state of Indiana has very, very few children on CCDF vouchers that are infants and very few that are on toddlers. From a policy perspective, we understand that's important. And part of this PDG program and this grant that we have is creating this referral slots pilot program to see how can we mitigate that challenge in the space and in the system. Other things that we're going to start doing with this grant is develop partnerships with IEDC. The first one of those is we're going to have a second round of the micro-facility pilot program. The first round of that was executed this year. We've gained quite a bit of information and knowledge about what that should look like as an auspice from a regulatory perspective, what works, what doesn't, what sort of structures from a business perspective works and what doesn't. And we look forward to working with IEDC to roll out a second round of this later this year. Also, another thing we are executing with IEDC through the Indiana Small Business Development Corporation is develop their ability to provide business support specifically for childcare businesses. ISBDC does a great job throughout their space around providing business supports for all types of businesses in the state of Indiana, especially small businesses, like what most childcare businesses are. We're going to work with them and to see how can we build out their already extensive knowledge in the space, and how can we get that potentially as a resource for childcare businesses that would like to take advantage of it. And the third thing that we're excited about is working with IEDC and the Office of Entrepreneurship and Innovation to create a Hoosier Employer Toolkit. There's a lot of, from my perspective, there's a lot of different mechanisms that already exist for employers to leverage their needs, right, which are employees, people coming to work, retaining employees, and childcare. And what we're looking to do here is to put all those in one place and also be coordinated between our office and IEDC on initiatives that they are doing, and the Office of Entrepreneurship and Innovation to say, how can we have childcare be a part of that conversation going forward? Another major initiative that we continue to work on is rural reform. The first one of these first one of these is FSSA, and then also as myself as starting this position. Had a similar slide up here on rural reform. In the last few months, we've done quite a bit. We've done extensive work as an office of trying to get this over the line. Those rules haven't been it's been quite a while since those rules have been updated in any sort of real way. We have made some progress. The childcare home rule package has been submitted to the Office of Management and Budget in December, and we're looking to do the center ones as well very soon. And then there's the rest of the rule package that will follow over the year. And we're also going to engage the Early Learning Advisory Committee, which the first meeting of the year, and the first one in a few months is next Wednesday here in the same building. And we're looking forward to engaging both ELAC as a whole and getting that going again, but also to engage for their input around the rules that exist and the things that we want to do as an office, and make sure that we're doing our two main goals from our perspective have been making sure that we're taking care of health and safety of kids, but also doing it in a way that reduces administrative burden and unneeded costs to childcare businesses throughout the state. So this is more of the informational side of the things. The updates on statistics. First off is the voucher side. Currently, total vouchers is 580. Wait lists is 33,199. Note these numbers are as of the end of December 2025. 94% of current vouchers are employed. Of current voucher holders, they're one or both parents are employed, and 90% of all voucher holders are in families of single parent households. This goes back a little bit more of the historicals. This one's more for reference than anything else, as you continue to see the decline in CCDF vouchers. These declines happen through attrition. I think that's, I think about it all the time, but it's an important thing to note, right? These are going down through attrition. People can, this is a pro-work, right, family choice, you know, family-driven and parent-driven program, right? We continue to see attrition in this program. And one of the major numbers that we view as very important on how we project what future cash flows and decisions we are going to be able to make as an office is that bottom line, which is reauthorization percentage. What the reauthorization percentage number is that's the way this program works, right? Is there's initial eligibility if family gets on a CCDF voucher, and then every 53 weeks we look at them again to say, hey, do they still qualify from an income perspective? Do they have a job, right? Do they still qualify? What that reauthorization percentage shows is like, hey, when that happens, how many of those people are falling off? And kind of surprisingly, we are starting to go back to levels of reauthorization percentage that we saw prior to the waitlist being instituted in December of 2024. Actually, there's one other thing I want to note on there. The on my way voucher number. You know, I know there was an ongoing discussion when we announced last year, when we announced a cap of 2,500 kids for on my way vouchers. You know, we never hit that cap. I just want to make sure that kind of point is made. In June of 25 was our maximum enrollment, and was at 2,281. We did not hit our projected cap for that on my way pre-K program. Here's a different way of looking at the vouchers. This is by age. You know, we all see the number there, right? Infants, there's 26 infants that have a voucher currently in the state of Indiana. Toddlers down 50% from the max in November 2024. And then, you know, 3s, 4s, 5s are down 31%, and school age is down 22% from the maximum in November of 24. Vouchers are down 36%. So shifting gears a little bit, going over to we're talking about the demand side, talking about CCDF vouchers, now going to the other side of things, the supply side. So currently, total regulated childcare capacity in the state of Indiana is 175,553. Year-over-year change is 2.7% year-over-year growth, and the locations are at 4,257. And we have average CESA location as well as stayed pretty constant. As we can see, we have started to see a turnover in general supply in the state of Indiana over the last 3 months. And this breaks them out by our 3 major auspices, which centers, homes, and registered ministries. As this shows, decrease in homes is larger than centers and registered ministries. Year-over-year capacity for centers is actually still continues to be 6% growth year-over-year, but that number as well has also started to turn over, and the number of locations has gone down over the last 3 months as well. So those are statistics. Now we're going to start getting in a little bit into the financial side of things, and soon I'll turn it over to Tammy Kiefer, OECOSL's controller. But first I want to walk through this slide real quick. This is a schematic that we've used in the past, and I think it does a pretty good job of showing depending on how you think of it, either the simple or complex nature of funding these vouchers and where that funding comes from. We fund our programs from a combination of state appropriated funds and then also federal block grants. Two of them, to be clear. First one, and the major one, is CCDBG, or the Child Care Development Block Grant. That is the major funding source for OECOSL. In 2025, $278 million was allocated to the state of Indiana. We received that money through a match. So state of Indiana puts up a certain percentage required by the federal government. And then because of the state doing that, we are able to receive the full amount the maximum amount that we could from the federal government. We have done that this year and last year. We've done that for many years as a state. There's a note on that. I want to note something as well is the federal fiscal year 26 number. That is an estimate. We will continue to estimate that until there is a annual appropriation there's an annual appropriation that's determined by Congress. And that hasn't happened yet. If you're interested, just note how the Health and Human Services bill is passed through Congress. That's the one that the Child Care Development Block Grant is in. It's an estimate. However, I'll also say that we'll expect it to be very similar to in scope and size to federal fiscal year 25. The other thing that the state of Indiana, from a federal perspective, funds that we use as a state for childcare are TANF funds. So state of Indiana any state and TANF, state can choose what they want to use TANF for. State of Indiana has for the last couple of years, and I think for quite a bit of the past, is allocated the maximum amount, 30% of total TANF funding to childcare and childcare voucher funding. In this upcoming year, that number is obviously still estimate as well, because it depends on what that grant looks like and what the federal appropriation is for TANF. But assuming if that's the same, FSSA is also allocated an additional $25 million from the TANF Working Families Fund to allocate towards child care vouchers as well.
Adam, if I may, a full breakdown of the TANF spending for the state of Indiana was in the preceding.
Oh, great. I don't have to explain that much then on this one. Thank you.
The full breakdown was in that. So for people curious what the other 70% is going for, they can go back and look at that.
Thank you, Secretary. So those are our federal funds. In aggregate, it's the majority of the funding for voucher programs, and our funding is in office, roughly 80%. Our state budget line items are two. There's been two historically, and there's a third that was added in the state fiscal year 26-27 budget. First one is the early childhood learning line. It's $39.4 million for this state fiscal year. And the other one is the pre-K education line. The pre-K education line goes to On My Way pre-K vouchers. The early childhood learning line goes to meet our match requirement for this Child Care Development Block Grant or CCDF fund. And then additionally, in state fiscal year, in this year's budget, there was an additional line item, a one-time state funding line of $147 million. If you're interested in the budget, it's called the CCDF Hold Harmless line. And that is used. I'm going back now. To this, going back to this, in state fiscal year 26, it's the top blue part. That's the $147 million of the CCDF Hold Harmless. All that money, we have used those funds to fund CCDF vouchers since appropriated, in the state fiscal year started in July. Without that funding, we would be even more on a cliff than the path looks different. We've had to make a bunch of challenging choices here at OECOSL and in FSSA around this issue, and the state of Indiana has. And I want to highlight that $147 million is a historic investment for the state legislature into childcare. And it's and sometimes that can get lost in all of this. And I think there is between the governor and the state legislature does understand that this is an issue, and it's an issue that you have to come up with an answer for. So all of this being said, these are our funding streams. All of these come into the Office of Early Childhood and Out-of-School Learning, and then they go out as vouchers. The majority of them go out as CCDF vouchers, and then the pre-K education line, that goes to On My Way pre-K vouchers. I will now hand this over to Tammy Kiefer, OECOSL's controller, to go through the financial numbers for OECOSL.
So looking at our financial summary so far to date from July through December, the actual spend for the entire OECOSL has been $263.4 million. And from that, $227.8 million are in voucher and On My Way voucher spend. To look at it in a little bit different way, you can see the actual expenditures by each of our programs in OECOSL. And you can see at the bottom that our funding has been 111 million state funds and 152 million in federal funds so far this year. Specifically looking at our CCDF, our most major program, you can see that we have been able to cover our obligated vouchers for 24 and 25 through the year so far. And I would like you to note, if you were here in March, you saw a very major shortfall in our funding for vouchers that has been reduced, showing here from 67 million to 37 million. So our cost containment programs are working and we're able to reduce our shortfall. I think that soon that'll be, we will be funded and flush. On My Way pre-K, we have spent 5.6 million, with 4.6 million of that being in On My Way pre-K vouchers.
So those are our major funds. In the rest of these, we can go through very quickly. This is our preschool. These will be available all online on the website, on the FSSA website. If you're interested in these are our, Tammy went through our major funds. These are our ones that are, they're just smaller. This preschool development grant, this is not the one I was discussing earlier. This is the one that we currently had as of last year. It stopped at the end of last year from a payment perspective. So, and we'll make, in the next one of these, you'll start seeing the one that we were awarded for 2020, calendar year 2026. This is our school-age childcare fund. This is a roughly $700,000 line item in the budget to go to school-age childcare grants. And then we have there's a small amount of funding we receive through various sources, state and federal sources, to fund some Head Start initiatives that we have in OECOSL. And we receive $170,000 of social services block grant is allocated to OECOSL as well. And then we have one more. We have a childcare licensing fund as well. As you can see, it's very small. That is what we have. Thank you for coming. Yes, like I said at the beginning, I know how everybody's busy, right? And everybody's got things to do, and time is precious, and appreciate everybody's willingness to drive down in here on a cold day. And at least the roads aren't as bad as they were earlier this week. And look forward to talking to some of you afterwards. So thank you.
Thank you, Adam and OECOSL team. We have received some questions. Many of them regarded increased scrutiny from the administration and what OECOSL is doing to ensure that we have no delays, which you addressed at the beginning of your presentation. Others regarded the possibility of frog funding being used, which right now is a question for the legislature. Before I read the questions we do have and can answer, a reminder that all questions that don't get asked here will receive a written response, and you can still submit questions to the Ask the Secretary mailbox at askthesecretary@fssa.in.gov. So the questions we have are from Martha Ray of Valparaiso, Indiana. First one is, an HHS ACF notice on proposed rulemaking titled Restoring Flexibility in CCDF is currently open for public comment until February 4th. The Federal Register documents regarding promulgation include verbiage on future invoices providers will be required to submit when these changes become effective and prospective payments are rescinded. What are OECOSL's plans for operationalizing these invoice submissions? What type of changes can providers and programs plan for to navigate these changes?
It's a very good question, and I think what we are observing that process, that rulemaking process, and we have some initial thoughts around what that looks like, but we want to be very cognizant that that's not a final rule yet. There's that rule process has quite a ways to go on the federal side, and once it's a final rule, we'll take a look at it very in a detailed manner and figure out what we can do. And I think the main thing about this, and I think this is the most important thing, is that we will be proactive in communicating with our customer bases, whether that's from the the families we serve through CCDF vouchers, but in this case, the childcare businesses throughout the state, right? And we want to make sure we want to be very cognizant if there are changes that need to be made in processes from our side, but then also from childcare business side, that we acknowledge that and give enough runway for everyone in order to make sure that one, it's understood, two, we are able to execute it. We want to be partners in transparency here. These QFRs to some extent are an exercise in transparency, but they go beyond that as well. And it's actually more important on the day-to-day things and the interactions that childcare businesses have throughout the state of Indiana with the Office of Early Childhood and Out-of-School Learning.
Since the rate cuts last year, some childcare providers have closed. What regulatory changes is OECOSL considering to make reopening facilities and opening new facilities easier?
It's a very good question. I think one thing we're doing currently, and I'm optimistic of getting it through our state rule process, is doing rule reform. I think before, one of the things I did before having this job is I helped get a childcare center up and running, and I looked at that regulation book too, and I said, "Gosh, no way! Got to find somebody who knows what they're doing," because it is complex and it doesn't make any sense, right? In a lot of instances, we want to clean that up. We want to make it easier, right? We want to say, "Hey, administrative burden. How do we make that easier? How do we affect operations?" And also to the point about opening from a capacity, how do we open more programs as a state, and what can we do? We've taken a good look at what are those things. I think that when we next week when we share those with ELAC, looking forward to that. Hopefully, people think we at least made a pretty good effort on there, and we're also now omniscient. And if there's things that if there's things or ideas, we are open to them. And we understand as an office how difficult it can be and challenging in certain situations, and we want to make it as easy to open childcare facilities and businesses throughout the state. And we want to do as much as we can to make that easier, while also being, also making sure that health and safety of kids are still the main priority. And that is a interesting and very at times challenging path to try to go through the eye of the needle. So
next, we have a couple of questions from Sarah Donovan. With so many schools closing classrooms or programs altogether, has that opened more spots for vouchers? Many schools are not seeing increased enrollment, so are these families not knowing where to take vouchers?
I imagine that there's localized supply-demand issues throughout the state, right? And especially coordination around CCDF voucher holders and childcare businesses and connecting the two. That's not something that we haven't done a whole lot of work on that, because I think that's because of the way that we think about it, right? What at the core, from an operational perspective, a CCDF voucher is a is given to a family, right, for a child. And, and then the provider base, right, says, hey, we would love to take these, right? We meet the requirements. We'd love to meet the requirements of what it takes to receive one of these. And, and we'd love to, right? We want to have those children and those families be a part of our communities. And I think that, from our perspective, we let the market, especially because how decentralized and local supply and demand issues can be around childcare, we leave that to businesses and families to make those connections.
Have state investigators been finding any misuse of funds, and what is being done to address that?
Well, can I ask you a follow-up question for clarification? It depends on what time frame, and this is what I mean by that, right? Office of Early Childhood and Out-of-School Learning, we already have processes. Before this issue came up in this space, we took it seriously. We take fraud mitigation seriously, and the main outside of in addition to the obvious reason that our goal is to be good stewards of taxpayer funds, is that also our funds are very scarce, and they have been for the last year. And every dollar that goes to, we want our dollars to go to the places that they need to, and that they should go to. And that's families, and that is childcare businesses that are trying to do the right thing every day, every hour, every minute, right? That is where we want our scarce resources to go.
The next question we have is from Jen Palmer. Is the reimbursement rate to providers for On My Way pre-K the same as for 4-year-olds receiving CCDF? Could that be the reason that On My Way pre-K did not make the cap?
Let me look into that a little bit more, and I will get back to you. That is, I don't want to say something incorrect on that. Well, that's a good question. I don't know it off the top of my head.
And lastly, we have a question from a Jacqueline Strong. I'll try to, it's a long question. I'll try to paraphrase it. Some childcare facilities are not seeing infants because the cost to manage infants and toddlers in a childcare program is higher than the cost for preschool-aged children. Is there going to be any review of reimbursement rates for infants and toddlers to allow more programs to accept them and provide more seats?
So we will be starting another cost survey. When are we starting it, Sue? We will be starting it this fall. I want to make sure I got the date right. So we're going to start this process again in the very near future to update what those cost survey data tells us, because our main goal through our reimbursement rates is we want to determine to the best of our ability what is the cost of providing childcare for different auspices throughout the state of Indiana. So that the question around infants and toddlers, we will be addressing that and looking at that and analyzing that again as part of that larger cost survey study that we will begin in the fall.
Okay, and that was our last question. Just again, a reminder, any question that wasn't asked during this period will receive a written response. Thank you, Adam and OECOSL team. Next, in 5 minutes, we'll begin the Division of Mental Health and Addiction. So don't go too far. Stay close. Of the Division of Mental Health and Addiction. If you have any questions, you can come back here and grab a note card and pencil and fill those questions out. You can submit them electronically at the Ask the Secretary box at askthesecretary@fssa.in.gov, and we will the questions that we can at the end of this presentation. Any questions that don't get answered will receive a written response. Thank you.
Welcome to the Division of Mental Health and Addiction Quarterly Financial Review. Can you hear me? There we go. How about now? Excellent. Sarah Sailors, the Director for Division of Mental Health and Addiction. We are going to actually take a little step back from this quarter review and look at some state fiscal year mental health and addiction spend from 25. We'll then talk a little bit about individuals served. We'll dig into each program area. You'll see financials on all of our individual programs. And then we'll go back to a high level to look at overall spend at a high level. And then we'll pass it on to our state hospital network and do wrap up with financial reviews for that system. If you have attended our QFRs in the past, you know that Secretary Roob has asked us to provide him and all of you with better insight into how we are spending our funds at DMHA, being more transparent. And so this is an attempt to share information more broadly about, one, our mental health and addiction spend as it relates to DMHA and then to our state hospitals. You'll see on this slide that within the mental health and addiction spend, we are at $369.7 million in state fiscal year 25. Of that, 60% was used for services, 36% in grants and contracts, and 4% going towards our operational support. This is a combination of state funds, federal funds, and dedicated funds. In state fiscal year 25, when you look at our state hospitals, we have spent $199.5 million, with 94% of that going directly towards patient care and 6% towards operational support. Again, this is state funds and mental health fund. When you roll these all up together, the overall spend for DMHA and our state hospitals together for state fiscal year 25 was $569.3 million. Of that, 39% went towards mental health and addiction services, 33% on our hospital patient care, and then 5% on operational support. Okay, now we're gonna go ahead and get into this quarter data and this fiscal year. So through our block grants, our community mental health centers, and our community behavioral health clinics, our system has served just over 89,000 adults. This data does only include 5 months of the first part of the fiscal year. We have 45,000 children who have been served and 134,000 total within that system. DMHA funds mental health treatment for individuals with serious mental illness.
I apologize, Sarah, can you go back to the previous slide?
I can't.
So those aren't unique individuals.
So those are unique individuals and new episodes together each month. So unique that month.
Right, but you could be served in August and be served in September and still count, correct? Okay. All right.
Okay, so our SMI program is mostly the community mental health contracts, the first episode of psychosis, and our specialty contracts under homelessness and workforce. And so this slide shows us that in December, our expenditures came in around 7.6 million. Year to date, our actual spend is around 38.5 million, and that's slightly under the budgeted amount of 38.8 million. We're forecasted to spend 86,227,000, and but we're budgeted for 86,264. So we do believe we'll land slightly under those expenditures. So looking good in that area. Same with our SED. So this is also community mental health contracts, PRTF match, and contracts for evidence-based practices and school-based prevention initiatives. So in December, our expenditures were just over 591,000. Year-to-date actuals were around 8.3 million, which is just over 1 million under our budgeted 9.5 million. We're forecasted to spend 19,054,000, and of that, we're budgeted for 19.74. So again, coming in very close to what we are budgeted. Okay, with that, I'm going to pass it over. We can talk about our CCBHC programs.
Thank you, Sarah. My name is Ari Nasseri. I'm the Assistant Director for Systems Transformation, and I'm going to be talking about CCBHC as well as 988 today. With CCBHC, our 8 pilots have officially passed their first year of implementation, providing all 9 core services in their designated service areas. So very excited about that first year, having passed that first piece, and now excited to look forward as well as take a look at review as we prepare to look forward. So one of the key things that we wanted to highlight, one of the big aspects of CCBHC that was really ideal for Indiana was the ability to address workforce. CCBHCs are 8 pilots in preparation for their implementation year, as well as during that first year, we're able to hire 488 key staff individuals to the 8 CCBHCs. So very excited about this increase in workforce, and this shows one of the aspects of CCBHC of taking a look at the community's needs, identifying what the staffing gaps are, and then addressing them by incorporating them into their PPS rate structure and being able to hire the right staff to provide the services needed by the communities.
So Ari, how many of these individuals of that 488 were working at community mental health centers that weren't in the CCBHC model?
Previous to being hired at the CCBHC?
Right. I mean, one of the concerns I think we all have is that we're paying CCBHCs significantly more money, and therefore they can pay their staff more money, and people at some level, right, they can be lured away with cash money, right? This is, so these aren't, so I'm just questioning, I guess the question would be, how many of those 488 are from CMHCs that are not currently CCBHCs? I don't expect you to have the answer today.
I do not.
Good.
Yeah.
I mean, tomorrow will be fine.
Yeah, absolutely. I will work on trying to get that as quickly as possible. Tomorrow is a Saturday, so maybe Monday. But we'll take a look into that. That's a great point. I think that is reflective of what we've seen as well with CCBHCs having to also compete with FQHCs and hospitals for these same staff. There is a waterfall effect of workforce, and we'll definitely take a look into that. Thank you, Secretary Roob. Next, another major piece of what we wanted to address with CCBHCs was access, both into intake and to clinical services. And when it came to access, we saw a major increase for the ability for CCBHCs to get folks in, as well as to provide a clinical service in a short amount of time. Indiana, in our first year, we had 87% of new patients received an initial evaluation within 10 days of first contact. That surpasses the national average of other CCBHCs in the most recent report and from 2020 from the National council, where 70% of new CCBHCs received an initial evaluation within 10 days. This is fantastic because as an average, that means that a lot of folks are getting it much shorter than 10 days. And so overall, folks are getting into services faster, which should provide a better chance for them to having great positive outcomes. Indiana's CCBHC was also very much tied as a key point for being able to support the crisis system. CCBHCs are required to have mobile crisis teams that are able to provide services 24/7 to their designated service areas. What we had in Indiana is that we required one mobile crisis team per county for CCBHCs in order to do that. And we set a goal for them to be able to reach individuals within an hour or within 90 minutes if they're in a rural area. They are also required to be able to have access to crisis receiving and stabilization services at a CCBHC for their designated service area. And in calendar year 2025, 15,038 individuals in crisis were served by CCBHCs. And of that 15,038, 2,617 were referred from local law enforcement agencies, which is a great complement to the ability to connect with local law enforcement, have a greater connection there, build better relationships, reduce the amount of time that law enforcement have to spend with these individuals, and really address their issues across the board in a way that doesn't end up seeing them going into the criminal justice system without need. So beneficial for law enforcement as well as the individuals being served. One of the things that we're looking at in terms of access, as well as how the CCBHCs are performing, first and foremost, is we're creating some metrics and some dashboards that we can regularly monitor and have conversations with our CCBHCs. This dashboard is created for three different purposes. First and foremost, to make sure that when individuals are coming into service, they are getting screened appropriately, that they're receiving all the screens they need. And that's being shown by the first 5 measures in white. Those are all screening measures for assessment for suicide risk, screening for social drivers of health, as well as tobacco use and unhealthy alcohol. There are a number of other screeners, but those are the ones that are directly indicated here. And then below that, what you see is what happens after screening. Are they engaging quickly and having follow-up with these individuals, which is incredibly important to be able to take someone from intake to treatment and in a quick, rapid time. So what we have here is, are they screening for depression and creating a follow-up plan for adults as well as youth? Are they providing brief counseling to patients with unhealthy alcohol use? And are they providing tobacco cessation intervention for tobacco users? And the rates that we see here are all really well. With youth, we have some work to do in the screening, but what's really important as well is the large positive percentages we have for their follow-up. That's incredibly important to be able to see that not only are they screening patients, but they're actively and quickly connecting with them in order to develop stronger treatment and clinical progress. And then down below of those totals, what you'll see are 2 parts of the iServe measure, which is an important measure that we monitor. And the first part is days from first contact with a provider and initial evaluation. So how soon an individual from the moment that they contact the CCBHC is able to get into their initial evaluation and receive an intake, as well as the days from first contact. So going all the way back to when they first contacted that CCBHC to when they were able to have an initial clinical service. And so here we see 2 days for this provider that was de-identified from first contact to initial evaluation, and 12 days from first contact with an initial service. So by monitoring these, we're able to have conversations and drive them towards meeting the goals that we have personally set at Indiana.
So Ari, and Sarah, I know you've heard me say this before, but but one of the 21 measures, right? One of the ones that that Indiana chose to include was to provide tobacco cessation and intervention for tobacco users. Okay. I have long said that tobacco is America's original sin, right? And had we not begun with tobacco, the country might look significantly different. But is that really where we want to be spending these scarce resources, or do we want to be focused more on suicide prevention, et cetera? I think I'm asking the question. I'm not reaching a conclusion, but I would ask those in the room who are involved in CCBHCs and in mental health care to have that discussion. Is this really where we want to be spending our time? Some people will say yes, some people will say no. I think it's worthy of a discussion.
Absolutely. And in fact, we're having discussions in the very near future, in fact, Monday being the very start of that, about taking a look at our outcomes and what our priorities are and where we really want to drive change.
And that's after you get me those other numbers, right?
Yeah, so I just want to be clear. Monday is not the deadline for every question you ask today. I just want to put that out there right now.
Next here, we see some comparisons of how Indiana has done in terms of screening against the national average, which is the line, that benchmark, as well as where CMHCs are currently reporting. So in terms of screening as well as follow-up for clinical depression, what's shown here is a percentage of patients that were 12 and older who received a screening and during the calendar year of 2025, as well as a follow-up plan that was developed if it was indicated that there was a need. And here we see 77% of those individuals did receive a follow-up after being indicated for clinical depression, which was well above the 51% national average from 2020's national survey. And CMHCs currently are averaging at 15% with that follow-up.
Okay, since you've used this twice, I'll reference something that 2020 study, that's pretty old, and it's probably 2018 data, right?
Yeah.
Right. So that may be the only study we have, but it's a pretty old data point.
Yes, I believe the National Council will be creating an update to that. I can't currently remember if they're preparing it from 2024's data or if it's in 2025, but they are coming up with a new one. And when that happens, we'll refresh it. And I hope to see that we are still well above the national average. And I know when it comes to the screenings, we just talked about this a bit in 2020, but again, we were passed when it comes to screening for unhealthy alcohol use, as well as counseling when it was identified that we were at 88%, which was above the 2020 62% national average, and CMHC's average was at 20%. And then here we have the CMHC county provider reports. So in 2018, there's legislation, Indiana Code 1229-216. I did not talk about the dashes. Those are breaks in between the numbers. That was created that required DMHA and CMHCs to create annual reports for their county fiscal bodies and their board of county commissioners for each county. In 2025, DMHA was able to develop this report into a data, and CMHC report data was combined in order to create one comprehensive dashboard. So we're very excited about this. And as you can see, there's multiple pieces shown here from the patients that are residing in the county and the kind of services they received, how many adult and youth were served, the top adult substances, youth substances, the top adult diagnoses. And this is what we were able to fit in a visually pleasing way. But there are other pieces that are not shown here, such as the top youth diagnoses, the referral source that patients had in order to come into service, and their patient satisfaction responses for adults and youth. And as you can see above, there is a tab that also allows folks to look at the single county and provider for each individual county and look at what those measures are as well.
So this is terrific data, right? But the function data in and of itself is not the point, right? It's using this data to create some kind of action, right? So how do we plan to use this data and for what actions do we anticipate? And I don't need an answer today.
I think I might have one.
Yeah.
Well, personally, I think it's a giant leap forward in our ability to be transparent and understand quality metrics, right? But also, I think it helps the local folks, your county councils, people who are investing in the gaps in their communities, understand what's missing, right? What are we already funding? What do we need? How can we best align our dollars to meet the needs of our individuals? So I think it'll help policymakers who are making big decisions about how we fund our system, right? To be able to see this data, especially at also the quality level for individual sites.
I assume this is easily accessible off the DMHA website.
It absolutely is.
Moving forward, what is coming soon is a crisis dashboard. And the crisis dashboard is going to have 3 tabs that show different pieces, but what we're focusing on today is the someone to connect to, the 988 call responses. And what we have here on the dashboard are the calls to 988 that have been received. And this dashboard is currently showing information from June 1st, 2025 to November 30th, 2025. There were 65,237 calls to 988 in that time period. The in-state answer rate was 97.34%, which puts us in the top 10. I believe we were higher than in that top 10 on the board, but currently national standards have not seen our update of 97.34%. The average speed of answer is 8.3 seconds, which is under Vibrant, the national administrator for 988's benchmark, which is 9 or less seconds for a speed of answer. And our average talk time was 17 minutes and 19 seconds, which is again under Vibrant, the national administrator of 988's standard of 20 minutes or less for an average talk time. It also shows the calls that were offered over time by month, so that we can see what trends look like. And here we do see that June and July were slightly lower, and then we have an uptick in August, in September. And again, that uptick kind of sticks and levels off for October and November. And this isn't exactly unexpected with kids going back to school in August and seeing an uptick in calls as they are going back to school and facing the stressors of life, as well as parents seeing their kids go to school. So this is great information that we're very excited to share. There's also going to be a dashboard that we have developed for someone to respond, as well as a safe place to help. And this information, once published, will be available for folks to see how we're performing with our 988 system. Here we have our 988 crisis response map. And some of the key things that we really want to highlight is, as of, I believe it was 2 weeks ago, we officially have coverage for mobile crisis teams across all 92 counties in Indiana. So that's a great thing that we're very excited about. A huge thanks to everyone who is a part of that. What we also have here is some different shading. And so you'll see a light greenish shade, as well as some stripes. The stripes indicate those counties that have been provided evidence-based practice training for MRSS, which is an evidence-based practice for providing a mobile crisis to youth. And so what we have here are 63 counties currently covered that have been provided MRSS training. And currently, DMHA is in the works to develop training for the rest of the counties, with a goal of hopefully seeing youth across all counties before we move into 2027. As well, you can see there are little houses with hearts. Those are the crisis receiving stabilization services. When it comes to the CRSS, we have 24 across the state that are indicated with those signs, and of those 24, 11 are CCBHCs. And now I'm gonna show some comparison data of our 988 calls and our mobile crisis responses and crisis stabilization services. There is generally, over time, from state fiscal year 25 to state fiscal year 26, the same quarter 2 being looked at, an increase, both in the calls. So a quite significant increase there. We believe this is due to a lot of marketing and engagement of those mobile crisis team providers in their community, as well as all our marketing campaigns to try and get 988 out there for individuals to know that it's a place to call, a safe place to call. When it comes to mobile crisis responses, obviously with all of the work that the team has done to expand mobile crisis across the state, we see an increase there from state fiscal year 25 to state fiscal year 26. And then again, when it comes to crisis receiving stabilizations services, that uptick of the services available across the state again, shows that difference from quarter two state fiscal year 25 to quarter two state fiscal year 26. Here we have a program summary of the 988 crisis system. In general, we have done quite a good job of trying to stay within the budget that is set, and that's shown in several pieces. So when it comes to the total expenditures for the response service, the personnel, we've kept that near to the budget. So it had a slight variance of $653. But what we were doing is having some increased management of how folks are recording their time and how time is being allocated for personnel. We also see that there is a very small variance in terms of the actual and budget for December 25 and year-to-date expenditures in terms of the external service expenses, but it was a $2 variance. And in terms of the of that, we think we're going to be able to hold our forecast to the budget, and we have those right on. So we believe we'll be able to hold that as well. And then when you look at the total expenditures across the board for the year, we were in the excess of 27,815 over our budget in terms of what we actually were able to put together, and 57,000 for the year to date is what we were able to do. So we believe we'll very well be able to meet that 27,000 variance that we're forecasting. And then again, down below, when it comes to the state funds, there was a variance in terms of the year-to-date spending of $118. We worked very hard in order to make sure that there was that it was as close to the budget as possible. And we believe that with the experience we've had, we'll be able to very well keep our forecast under and close, if not close to the budget that is set for state fiscal year 2026. Now I'm going to pass it on to Kelly.
Thank you. Good morning. I'm Kelly Welker. I'm the Division Director of Addiction Prevention and Recovery here at DMHA. So just going to kind of highlight some of the programs that we use our funding for. With our state opioid response grant, we pay for room and board at recovery residences for people with opioid use disorder as well as stimulant use disorder. We also use that funding to purchase and distribute naloxone throughout the state. Some of our state treatment funds goes to support our regional recovery hubs that have peers in them that help access people to any services they may need, as well as lift rides through 211s that will get people to treatment and recovery services. And then finally, with our substance use prevention, treatment, and recovery supports block grant, we use that to provide residential treatment for those who don't have a third-party payer and really focus on our priority populations of pregnant women and parenting women. Just some metrics from some of this. So for state fiscal year 26 quarter two, we did over 1,500 rides. Over 203 people were served in our recovery residence through our DMHA electronic billing system. Over 900 people were served with our substance use disorder treatment. And then over 68,000 doses of naloxone were distributed in quarter two. I did want to highlight, because you can see in quarter one of state fiscal year 26, there were over 90,000 doses. September is recovery month, so that actually leads to a lot of outreach events, celebration events. So there's typically higher need and requests for naloxone. And then for quarter two, that kind of highlights our holiday and winter months where the requests go down. And our vendor Overdose Lifeline does a wonderful job of not distributing large doses, making sure that what is being distributed is going to be used and not sit on a shelf. And this has been a trend since 2023, so this is actually pretty in line with what we have seen over the years. Moving on to some of the funding. One thing I do want to kind of highlight, you will see a little bit of red in here. all of our funds are dedicated. So when you see the state funds zero throughout, our dedicated funds are some of our unrestricted opioid settlement funds, and then we have federal funding. In December, our federal payouts go out to our CMHCs for their pay for performance. So we do expect to see this balance out as the years goes on. DMHA gambling program overview. So we currently have provider agreements with 14 agencies, and they help provide treatment and services to those, also help administer a problem gambling toll-free line, and then provide oversight to agencies with that. And then some of our gambling program metrics. For quarter 2 of state fiscal year 26, over 276 unique clients were served, over 112 new intakes, 107 people signed up for the voluntary exclusion program, 33 new people enrolled in the internet self-restriction, and we had 185 calls to the gambling helpline. Regarding the gambling budget, you can see there is just a little bit of red on here. And I did do some research with our problem gambling coordinator. With our vendor contracts that we have, they bill semi-annually and annually. So this kind of hit our semi-annual notice. So this will balance out in the end because there won't be any more claims for a while on that. Moving on to substance use prevention. We currently fund 32 community grantees and 5 colleges. So this map just kind of highlights where those services are being offered. And then with our substance abuse prevention, we are on track for spend. You will see one red in there, and that is our prevention staff is supported by our substance use prevention treatment and recovery support block grant. And there is a 5% admin cap on that. So we will at the end have to balance that out, but that is very typical. And then opioid settlement. So we are currently still receiving settlements as they come along. Over the next 18 years, we will be receiving over close to $1 billion at this point in time. The Attorney General's website houses all of that information, and there is a breakdown of where every city and county and township, what they receive. And there is a 50-50 split between the state and the local units of government. For our opioid settlement, one thing I do want to highlight that is going to be changed behind the scenes. We want to ensure all of that our restricted opioid settlement funds are going for services and not admin. So all of the admin, so the personnel will be shifted to our state addiction treatment funds, which are unrestricted funds. So this will balance out in the end. So all of this funding will go directly to services within the state. Moving on to our opioid treatment programs, also known as methadone clinics. We currently have 26 spread throughout the state, highly regulated DEA, IPLA, SAMHSA through that. And then here is just a map of where all of those clinics are located. And then with our metrics for state fiscal year 26 and quarter 2, we had over 11,800 people served. Over 1,200 admissions and just over 1,200 discharges through that. And lastly, with the funding, this funding is a little bit different. So this is one where we bill back to the opioid treatment programs at the end of the year. So it always ends up being a zero. There was a slight increase. We did have a couple concerns with our OTP, so we made a couple unannounced site visits, but that's just kind of a one-off. So this will balance out in the end. I will pass it on to Becky.
Awesome. Thank you, Kelly. Good morning, Becky Buhner. I'm the Deputy Director, Chief of Staff at the Division of Mental Health and Addiction. So first of all, Recovery Works, which is also the Mental Health and Addiction Forensic Treatment Fund. This funding was started initially to help support gaps when individuals are coming out of an incarcerated setting. So whether that be a county jail or a Department of Corrections facility in order to ensure they could continue receiving services until they were able to get access to Medicaid or a third-party payer. This fund currently is a $12.5 million appropriation. So just looking at some of the metrics, so WITS, which is the treatment system that we use to collect the data for our recovery works, you can see there the total spend for the second quarter, just over 1.5 million. And those are direct services to individuals that are enrolled in the program. The newly enrolled individuals in the quarter, just over 1,600. And then we have, because folks are able to stay in the program as long as they are eligible with a redetermination at a year, it's just under 13,000 that are receiving services. The number of referrals that we received through our contracted entity, PACE, which not to be confused with the state program, Secretary Roob, we have just over 800 referrals that came in through PACE. And then Unite Indy, we continue to highlight this program every quarterly review. And really because this program does something very unique in that it assists individuals with a felony with getting transportation in places where transportation is usually very hard to access. And it helps to make a connection between employers and the individuals that need employment. And it has proven to, so folks have been able to stay in their employment. There's improved retention, and we're currently operating in 12 counties. And so just really positive outcomes with this program, and knowing that employment is foundational for folks that are coming out of corrections in order to get access to and maintain their recovery. So this is the Recovery Works financial summary. You'll see that the personnel services, those that's our administration, our staff within DMHA. External services, those are our contracts that we have. We did see that there were some contracts from a past year where payments came in, and so they hit this year in the funding. And so that is reflected in this number, which is why it's a little more than what we had anticipated. The social service payments, again, those are those WITS payments that we have. And so during the current month of December, we had just over 600,000 in payments. And we do expect, we have budgeted right now just over 6.2 million for the service payments. We will continue to monitor this. As you all know, this fund did get a reduction this year. And so we previously had more funding in that service bucket. So we continue to monitor this and make sure that we are staying within what we ideally underneath the 9 million is the maximum we could go in this fund. So Mental Health Funds Recovery Program, this is a contract with Inticare, and you will see that also on our contract sheet. And this is where Inticare works with our provider network and contracts with them to do services on our behalf to assist with getting individuals access to Medicaid and or other services. And so this funding goes directly from our providers out to Inticare out to our other provider network. And then there's a 4% admin fund that comes back to DMHA. So at DMHA, we are responsible for certification and quality assurance as it relates to our provider network. This includes our community mental health centers, our addiction providers, residential providers, as well as the recovery residences. And we have a small but mighty team that does all of our quality assurance. And this shows here that we had that team review 135 provider complaints during this quarter, and had 614 critical incidents that they had to investigate in some way. The trends that they see when they do their reviews, you will see these are very similar to the past quarter. And bottom line, it still all comes down to documentation. So our team, while they are doing the quality reviews, they also provide some technical assistance and help folks to understand how to get their documentation, how to improve it so that it is up to our standards. This is a list of all of the specific site visits. Just a reminder that when you look at the private mental health institutions, those are always unannounced. And so they just show up at those facilities, no warning. The other ones are usually announced unless it is as a result of a complaint or a need for investigation. And as I said, our team does spend a lot of time on technical assistance. And one of the areas they focused on recently is really working on the corrective action plans. As you can see, we had 19 under the outpatient and 8 under our private mental health institutions, 2 for recovery residences, and 3 for our opiate treatment programs. And they have spent a lot of time working with the providers to make sure that those corrective action plans are plans that we can accept and that also can be accomplished and that will meet our certification requirements moving forward. This is the DMHA administration summary. So this is our staff at DMHA. We do have some contracts, and then as you will see, our ID bills are running a little bit high. Again, these were, there was an increase in these, and so we've had to adjust some things to focus on that. And as Kelly mentioned earlier, we do have some staff reporting of their salaries that still needs to be corrected, and so we are still working on that and hope to have that done by the next quarter. This is our major contract summary. Intercare, again, that's the one I just talked about. That's the mental health funds recovery. The CMHC and CCBHC, this is a combination of all of our provider contracts, as well as 2 below that, the one that is for the affiliated service providers. Those are our provider contracts. And then we have 2 contracts with the Indiana Council of Community Mental Health Centers. One is to support group homes and the work that they are doing within their group homes. And then the other is called a bridge grant. And that is funding to support our non-pilot sites, non-CCBHC pilot sites, to ensure that they can continue to build their workforce and build their infrastructure and provide services as close to the CCBHC expectations as possible. Sorry. And then this is just the financial summary. So this is a summary of what everyone has already talked about, from Sarah to Ari to Kelly and then myself. And so this is just all on one page for you. And then this is a breakdown of our funding sources, state, federal, and dedicated. Again, the total amount. And then this is our Medicaid funding that we have that comes through DMHA. And this focuses, we have 3 state plan amendments. So the 1915 I's are state plan amendments. We have the wraparound amendment, which serves children. And then we have the adult mental health habilitation. And then we also have the behavioral and primary healthcare coordination, BPHC. Listed on here also is the inpatient psychiatric. Mental health rehabilitation is often referred to as MRO, Medicaid rehab option. And that's where there's a lot of conversations around the services offered through that. And then our CCBHC, the Certified Community Behavioral Health Services, just want to note that is as Ari talked about, a new program, January of 2025. And we are running under forecast on that. So that's great. And then other mental health services are clinic option services. And then the bottom one is residential treatment for child and adolescents.
So before we get to the state hospitals, I do want to make this is a comment, not really a question. For those of you who are too well to attend the presentation that I'll be doing this afternoon, one of the slides that I have in there looks at mental health and addiction funding, the funding that we spend inside of DMHA and then the funding that we spend inside of Medicaid. I think it came, frankly, as a surprise to many of us that we were spending that 70% of FSSA's funding on mental health and addiction is actually spent through OMPP rather than through DMHA. So I think we've recognized a need to better coordinate between the health plans and what's going on at DMHA. So that's one of our projects for 2026. Thank you for your presentation.
Well, good morning. I think it's still morning time here. Katrina Norris. I am the Executive Director for the Indiana State Psychiatric Hospital Network. And today just want to really share a little bit of clarity with you where our network is performing and where our pressures are building and where we must stay disciplined to continue to meet expectations. So we continue to serve the high acuity patient population. They are increasingly more complex in nature, and the demand curve is not flattening. So at the close of the calendar year, we had served 1,176 patients to date. Our metrics on occupancy, again, stays pretty consistent. High occupancy with the average for the entire network at the end of the calendar year around 83%. It is a little skewed in this second quarter of the fiscal year because of the adult and the youth populations shifting. We saw a decrease in youth referrals in the last quarter, which is not really uncommon during the holiday season, but an increase, of course, of the adults and the forensics. Our target as a network is to remain around 85%. Not only is it an industry standard for staffing and safety, but it also helps us in the incident that we would have a surge and need that space. This is our length of wait metric for the last quarter. Obviously steady throughput still happening, but the system is absorbing more forensic and long stay patients than ever before. So the civil access continues to tighten as the forensic volumes continue to grow. It's a structural shift that we must plan around. It's not something we as a network can treat as temporary. And you will really see it in this slide. So our admissions remain steady across the network, but the number of individuals that we are currently serving reflects longer lengths of stays and fewer discharge pathways. So it should be noted, obviously we have very complex, very acute patients pretty much all the time, but the mix of those individuals with IDD, dementia, and TBI continue to drive long-term occupancy, and it impacts our ability to meet the current demand. To date, we have around 130 Hoosiers on our wait list. That includes internal transfers. Our staffing has been pretty consistent from July until December. We saw a 4% drop, which obviously, again, can impact our throughput. Our contractor staffing remains small but essential, averaging 28.3 year to date. We are experiencing a nursing shortage at most locations, and honestly have been relatively unsuccessful in onboarding state positions, which again creates reliance on contractor staffing. I don't think we're alone in that nursing shortage. Our contract summary is here. Our largest contracts, Cura, Cerner, Oracle, Cerner is Oracle, my apologies. Community Health Network, these are core operational and infrastructure services like food, the EMR, clinical partnerships. We continue to align calendar year 26 goals, and the message has been clear to the hospital leaders. Every contract must support throughput, safety, or modernization, and be competitively procured with no exceptions. This is a hard one. This is the competency restoration slide. I do want to make note from previous reports in the last quarterly financial review, the DMHA data team and central office staff have worked diligently to improve our reporting system, including enhancements to the repository system. They have scrubbed data, they have validated data. Shout out to OGC Gatekeeper for her assistance in that as well, and getting the right data so that we can report out and plan for the importing into our system. The ICST referrals have surged to a level that is unsustainable, a system level shock that no state hospital network can absorb without redesign. We are consistently partnering with stakeholders to work on policy initiatives and solutions, including relationships with court services, Office of Behavioral Health, of course, the CMHCs and CCBHCs, and system of care coordinators. I've said it here before, and I'm going to say it again. We have a competency crisis in this state. So the slide reflects that pretty clearly. So keep in mind, I only have 726 adult beds across the 5 hospitals that serve adults. There's a significant number of people who are also going to be unrestorable, which means unable to ever aid in their defense. So when we have unrestorable patients, they stay with us a very long time. Their charges don't magically go away. And you can see the projection for the calendar year in excess of the number of adult beds that I have. That data was pulled on the 9th of January. This morning, there were 49 referrals already this month. So some metrics here about some of our efforts to relieve pressure valve, if you will, the forensic referrals. Project Create is our pressure valve. It's a private inpatient pathway for low acuity forensic referrals that preserves the state hospital beds for the highest need individuals. So our active Create patients nearly doubled from July until December. It just speaks to the influx of the forensic dominance on our system. These are those competency contract metrics. You can see that both contracts are still pretty early in the cycle, but they do not, this data does not reflect the claims for December as they had not been paid yet. This is monitored very closely to assure we meet the demands as well as utilize every resource in our control for problem-solving efforts. Here's our financial summary for the network. It reflects $3.7 million under budget year to date. That's a positive variance, but it's driven by slower than expected expenditures. The NDI is our largest outlier with a projected overspend of $6.2 million due to acuity, staffing, and operational intensities. But it should also be noted that the NDI has significantly higher volume than any other location. They do almost double the admissions and discharges, but that's due to a prescribed length of stay at that facility. If you're familiar with the NDI, it's a vertical, 6 floors, no green space. We don't want to keep people there unnecessarily long because it can do more damage to their mental status. And it was also the vision of the opening of the NDI in 2019. So our network challenge is balancing the rising demand and with predictable spending, especially with that forensic volume that continues to reshape our system. Should also note too that the more forensic referrals and the less youth referrals impacts our ability for revenue. Expenditure stayed pretty consistent through the second quarter. There is a little spike in overtime there, but we also plan for that because December was a 3 payroll month, as well as the holidays that impact that. And this is just an initiative update of what we're doing. So we continue to investigate restructuring roles and workflows so that we can stabilize staffing and improve throughput, as well as efforts to our clinical models so that we can better serve some of those long-term and high acuity patient populations. The discharge work group was focused on reducing avoidable delays and expanding some community pathways, which is essential for improving the civil access. And through the end of the year, it didn't really produce the results which we had hoped, but that's no fault of those involved or the efforts that were made. It's just the struggle that we have to continue to maintain our community partnerships and leverage out-of-the-box thinking to get people that are safely ready to return to their communities to a less restrictive setting. So I will just leave you with this. The pressures we are facing are real, they're structural, and they're accelerating, but so is our response. Our success our success in calendar year 26 will depend on disciplined execution and cross-system coordination and a relentless focus on throughput and safety.
Thank you. Can we go back to the slides, Katrina, you know what I'm gonna,
Where are you going?
just back to the slide that looks at that slide, right, that slide.
Read your mind.
Yes, well, it's not a very interesting book. The, squirrel, so this is, I mean, I say the same thing at every quarterly financial review, right? Which is in my last tour of duty here, we had the same number of beds and there were no forensic patients anywhere but Logansport, right? Now there are almost nothing but forensic patients, which means that the seriously mentally ill are being treated in the community or they're becoming homeless. So we are unfortunately, we are the tail on the criminal justice dog here, and we have no ability to control, realistically, we have no ability to control this. So I know we have worked and spoken to others, both legislators and the judicial system, but by the budget session, we need a different answer, because we can't continue to do this. And for those in the room who are mental health advocates, I'd encourage you to speak with your representatives and members of the Supreme Court about the dire nature that we have here, because we are, it costs to get, and by the way, I would prefer if prospectively you talk about a competence restoration problem in Indiana rather than an Indiana competence problem. But that's
Noted.
but I mean, they did win the national championship. I mean,
True that.
but back to the point here, on the competence piece, the restoration cost of this, it costs us to house a person, one of the humans that we house. It costs $1,000 a day on average. These are ballpark figures to give the people in the room some sense of this. And it takes 100 days to get somebody competent, whether that's in our system or whether that's in our outsourced. So that's, I mean, it's a pretty easy math problem, right? 100 days times $1,000 is $100,000. So this cannot be the most efficient way to get competency restored, to spend that amount of money. 842 times 1,000 is a lot of money that we could better be spending, in my opinion, on expanding CCBHCs if that's what we choose, or something else. But we have no choice but to spend it here. So that's my editorial comment on this. It's no different than every quarter, but it needs to be different prospectively.
Absolutely.
Thank you.
Thank you.
Okay, we have received a few questions. Just a reminder, you can still submit questions by emailing the Ask the Secretary inbox at askthesecretary@fssa.in.gov. And if your question isn't read here, it will receive a written response. First question is from Jason McManus. To what do you attribute the percentage well above the national average for evaluation after first contact? In other words, what has Indiana done differently than other states?
I think there's a few things. One, I think it's about a lot of concerted efforts among different folks at DMHA. Wendy Harold, our data director, as well as the whole team, having good connection with our CCBHCs, describing what we need to do in order to collect that data, in order to represent it, as well as having good, consistent relationships with them so that we're all on the same page of what we're trying to do. I think every state tries to do their best, but we got also the opportunity to learn from the lessons of those in the past and work off of some innovations that have been developed within our own own network of folks who are CCBHCs. So I think it's a lot of different pieces that allowed us to do that. But overall, it was putting alignment among all the different stakeholders that were a part of this implementation, the Indiana Council, the providers, all of our folks at DMHA and OMPP to really work at this and drive folks in the right direction.
The next question is from Greg Alexander. Can you comment on the data sharing of the CCBHCs with the patient's primary care providers?
Great question. So that's something that we're actively working on. CCBHCs have a requirement to develop care coordination agreements with local primary care providers, especially FQHCs in their area, as well as hospitals and a slew of other providers in their designated service areas. A lot of this takes time to build those relationships, but it's also about the fact that on the FQHC side, there hasn't been that same sort of requirement to directly build those relationships with FQHCs. I think both sides of the house, in terms of the different models of care, are interested in doing that, but it's really about driving it. And we have authority over the CCBHCs. We don't have authority over the FQHCs. So I think in order to bring them to the table, we're developing connections with IDOH in order to bring the primary care providers to the table, as well as in situations where CCBHCs have that connection with FQHCs. That's something we intend to do a lot going into this year, looking at what those care coordination agreements look like, how we can better develop them and standardize them so that data sharing is better across both sides.
Okay, thank you, DMHA team. We will reconvene at 12:30 for the Office of Medicaid Policy and Planning. Thank you.
Hey, good afternoon, everyone. We're going to follow our typical schedule and go through the overall results, look at enrollment, expenditures, and highlight a few watch areas for the group. I would say the biggest update we have this afternoon is that we are now comparing actual results to the December forecast. So for those of you, and I see familiar faces in here, for those of you who attended our last quarter and the results were 12% below forecast, we're going to see smaller variances now because we've refreshed the forecast to align with actual results. And so what we expect to see are variances that are much smaller than we had seen in previous quarters. So when we're looking at the enrollment is now 2.1% less than forecast. Both managed care and fee-for-service are showing below forecast, and then our expenditures are 4.4% below forecast. So with the new forecast, we're still coming in a little bit under what was in that forecast. If we start with enrollment for managed care, our story is really still the same as it was last quarter, and that is we are continuing to see declining enrollment for the HIP and Hoosier HealthWise program due to the new processes for redetermination. So we'll look at this a little more in detail. We had seen a slowing of the decreases, but then in the last couple of months, they sped up again. So we're already below forecast for those areas. For enrollment for fee-for-service, we're pretty close to the forecast, 3.7% below forecast. Similar to prior quarters, some of the areas where we're seeing less enrollment are really in the emergency-only services and the limited benefit areas. So overall, total 2.1% below forecast for enrollment. And that sort of gives you a clue sometime as what we might see in the expenditures.
Kathy?
Yes.
Sorry. Sunshine was on this morning. She had a 1.66 number, and you've got a 1.77 number.
Can
you go back to
overall enrollment? So I think we'll have to follow up. So this is from our reports.
It's
enrollment.
enrollment at time.
Yeah.
Is there a snapshot?
Yeah.
She was looking at, okay.
Right.
So-
Okay.
so-
This is the average. Okay. I got it.
Okay, so Thank you, Paul. So yeah, just a reminder, these are the average year to date. So this is the results from July through December of 2020.
So at the end of December, that was 1.66.
Yes.
Okay.
Yes. Okay, now moving on to expenditures. We'll touch on these at a high level and then we'll go into a little more detail on these. Overall, as I mentioned, the expenditures are 4.4% below forecast, and that's in total. The expenditures for managed care and fee-for-service, they're both pretty close to forecast. They're off by less than 1%. Fee-for-service is off in the direction we don't really want to be. It's coming in a little higher than forecast, and so we'll go into some more detail on that one. The manual expenditures came in better than forecast, and the biggest variance we have, I'm sorry, the manual expenditures are the biggest variance that we have. The other expenditures and collections also came in better than forecast. So if we look at each of those separately, for managed care, you'll see overall the results are positive, 0.8% less than forecast. So again, very close, which is what we expect when we have a forecast refresh. You'll see Hoosier Care Connect is showing a slight negative number, and that has to do with some retroactive rate adjustments that happened in December, that they came out a little bit different than the forecast, but it's not a run rate issue that we should be concerned about. It was really a one-time adjustment. So managed care coming in a little bit better. If we go to fee-for-service, as I mentioned, it's coming in about 1% higher than forecast. And the biggest driver of that is the bottom line there. It's the state plan. The fee-for-service state plan has come in quite a bit higher. And so there are several areas, it's not just one area, several areas that we're looking at, including pharmacy, durable medical equipment, physician services, and home health services. So those are some of the ones that were coming in a little higher. The home health services is one that we are concerned about because we've seen those costs going up. We included a 20% trend in the forecast, and they're still coming in a little bit higher than that trend. The other areas in general, the waiver services are lining up as expected. We've got a couple of negative variances. One, the CIH waiver, that has to do with some residential habilitation, and we've got a amendment to adjust some of those rates. So that's one of the areas that we've already addressed, but it's really the state plan, the fee-for-service program that we're going to have to continue to research. Other expenditures and collections, right? For those of you who've been here before, you know the main driver of this is always the pharmacy rebates. Those are difficult to project just because of the lag and the processing, and so we tend to see higher and lower numbers coming through, and we're currently showing that those are coming in better than we were expecting, so that's lifting up that category. And then finally, the one that has the biggest variance, and this is our manual expenditures. And this is really primarily due to timing issues. If you'll see the two top rows, dish payments, we're showing 83 million better than forecast. And that's because there was a set of dish payments and one provider had appealed their eligibility, so it took a little bit longer, but that 83 million was actually paid in January. So we'll see that showing up in the next results. The other larger one is our nursing facility supplemental payment program. And you'll see a smaller number, much smaller number was paid than was expected. And that has to do with our managed care program that's paid through a state-directed payment. And CMS has some new regulations in place, and we're still working to get approval for those managed care payments. So this would be another one where hopefully in our next quarterly meeting, we'll be able to say that those payments were approved and those have been made. So they are primarily some timing issues, and we would expect to see those payments showing up in the future. So now to our watch areas. We already discussed this a little bit, but We're continuing to look closely at the Hoosier Healthwise Healthy Indiana Plan and the enrollment changes there. So the declines had slowed a little, and now they've increased a little bit more. We do expect to see those enrollment declines for the first quarter of this year as well. But one of the things we're looking at closely is we don't expect to see a one-for-one impact in terms of if the enrollment drops, we'll see that same drop in expenditures, because we believe these individuals who are not continuing on coverage have a lower acuity. So we expect to see a little bit difference in that, and we want to make sure that we're measuring that appropriately. Another watch area that we've been updating every quarter is ABA therapy, and we're actually seeing some encouraging results here in terms of the number of recipients year over year now is showing a 15% year over year growth rate. And in previous years, it had been closer to 25. So we're seeing some moderation there. And we're also seeing a much more notable slowing in the expenditures. So that means that we're seeing less participants, and those participants are receiving a little less hours. So we're really not in the place now where we would consider this to be sustainable, but there is a whole ABA work group results that are going to be implemented. So we would expect to see improvements in these results later in the year as well. Finally, some of the changes around our attendant care program. One of these is we're looking at pathways here, and we're seeing that the results, if you look at the fourth quarter of the prior fiscal year and in the first quarter of this year, we're seeing a decline in the pathways, but the decline, you can see the pattern there is slowing a little bit. And the offsetting area of coverage that we're watching here on structured family caregiving is showing a steeper increase. So we're a little bit concerned about what that means in total, and we're going to have to look at all of those in total and combine that with home health as well, because we're getting ready to set the capitation rates for the third year of pathways, and we want to make sure we have a good understanding of what's going on with those expenditures. And so for home health, we are seeing increases in expenditures for pathways. And the pattern for home health is a little different. We don't see a lot of individuals with 60 hours of care per week, but we are seeing increases overall. So that's one of the things that we have to put in the total there when we look at what's going on in pathways. And then we also did take a look, the last note around home health. We looked at the results for our HIP and Hoosier Care Connect and Hoosier Healthwise plans. And these programs represent a very small percent of all the home health spend, about 5% of the home health spend. But you can see for the fiscal year, the prior fiscal year, the trends are very high. We're seeing from the beginning to the end of the year, 71 and 90% increases. So even though it's a small amount, that sort of a trend is concerning because it can turn into a large amount pretty quickly. So we're going to continue to look at those amounts as well. So that was the last of the watch areas. I'm going to turn it over to Leslie.
Good afternoon. Good afternoon. We wanted to share with you the Medicaid assistance financial position year to date. With our expenditures coming in at 8.8 billion and our IGTs and federal funding coming in at 6.7 billion, we have a general fund need of 2.1 billion. The general fund appropriation year to date would have been 2.4 billion, which leaves us with a surplus of 312 million. Kathy mentioned the updated forecast. Our updated forecast projects a state fiscal year surplus of 314 million. So we're on track to meet that projected surplus.
All right. This piece of the presentation will be focused on our mental health benefit and our pregnancy promise program. So we'll take a look at the mental health services that Medicaid covers, and then from there, we'll look at a number of breakdowns, including some utilizer data, some expenditures, and a further look into the proportion of services that are provided through our CMHCs, or community mental health centers, as well as a drill down into one of our more highly utilized services, which is skills training. And then we'll do a recap of total expenditures, which will include mental health and ABA and substance use disorder treatment, which will also incorporate some of our previously shared data at a prior QFR. So before we get into the data here on this slide, I'd like to give a quick overview of what we cover. So Indiana Medicaid covers a broad range of mental health benefits, which include inpatient services, outpatient services, partial hospitalization programs, intensive outpatient therapy, screenings, so think of like depression screenings, mental health pharmaceuticals, and then there are some specific benefits that we do solely reimburse under our fee-for-service benefit, which would include things like psychiatric residential treatment facilities for members under the age of 21, Medicaid rehabilitation option or MRO services is an example, as well as some of our other 1915I services. A quick call out here on the slide, there is some nuance to ABA being categorized as a mental health service. So programmatically, we do cover ABA in our mental health service category. ABA addresses primarily people who have autism spectrum disorder, which is a neurodevelopmental disorder in the DSM-5. So because of its kind of unique nature of ABA, we did pull it out into its own category, and you'll see that there on the bottom row. The remaining services that we cover are directed toward, the treatment of psychiatric conditions. So think of, schizophrenia and those subtypes, your mood, your affective disorders. So bipolar depression, for example, anxiety or stress related or dissociative disorders. We cover services for syndromes that are associated with physiological issues. So sleep disorders, eating disorders, personality disorders, and then other behavioral and emotional disorders that might typically begin in childhood or even in adolescence. So some examples would be ADHD or conduct disorders. Another call out on the data on the slide and the next few slides is that it is inclusive also of our pharmacy, so pharmacy services for mental health. So on the slide, we do give a high-level look at the total membership who had a mental health diagnosis in calendar year 2024, and then we break that out further by program. Of those members, the second row is showing the member count who were actually receiving services and pharmaceuticals for mental health during that calendar year 2024, so about 73% overall. The third row then shows the total cost of the mental health benefits. Again, this is including pharmacy, but it does exclude ABA, as those are separately shown in the last row. The pharmacy spend, which is included in there, is about $455 million. So if you were to take the cost of mental health minus ABA and minus pharmacy, you're looking at about $591 million. So in calendar year 2024, the proportion of our total membership who had a mental health diagnosis was about 35% of our total members. This is pretty aligned to studies that have looked nationally, which often show about 1 in 3 members in Medicaid have a mental illness, and then 10% of those members also have SMI. The active treatment percentage estimates nationally for Medicaid enrollees typically falls in the upper 50% range. So Indiana is above that, with around 73% of our members, at least in calendar year 2024, that have a mental health diagnosis receiving mental health treatment. And then lastly, if you were to add ABA into the total mix, the cost of the mental health benefits becomes almost $1.493 billion and some change. Of the total 444,852 members who were receiving the mental health benefits over that calendar year, Approximately 30% of them were receiving them through our community mental health centers. The program with the highest percentage of members receiving those services in CMHCs was Hoosier HealthWise at about 40.8%. And then the lowest was our Healthy Indiana Plan, or HIP, at about 21%. Other provider types that render mental health services might include, individual provider types like psychiatrists, psychologists, licensed mental health counselors. It also would include things like outpatient mental health centers and psychiatric hospitals. Of the $1.047 billion spent on mental health services in calendar year 2024, again, excluding ABA, about 34% of that money is going to the CMHCs. And we can visualize this in different ways. So if we wanted to look at that proportional cost of mental health services in CMHCs against the cost of mental health services, but pull out pharmacy, that percentage would be substantially higher, around 60%. We wanted to drill down a little bit more into a service that has high utilization, which is skills training. And skills training is a service that is intended to help members build, maintain community living skills, maybe even gain skills needed for employment or skills needed to just maintain that independence in the community. About 12.5% of our total members receiving mental health services are receiving skills training. And the program with the highest proportion of utilizers is Hoosier HealthWise at about 23.5%. Of the $1.047 billion spent on mental health services in that calendar year, again, excluding ABA, 21% of that money was paid for skills training services. And if we wanted to look at that proportion against the cost of mental health services, but pulling out pharmacy, then that percentage would be higher. It would be about 37.7%. And we showed in the last slide that members in all of our programs were accessing the service, but all of the money, or the $223 million of those costs, just a call out, are getting reimbursed through our fee-for-service benefit, because skills training is what we call a carve-out from managed care. Skills training can be reimbursed through, and here's our acronyms here in Medicaid, so AMHH, CMHW, MRO, MFP, PRTF waiver, as well as the PRTF transition waiver. However, 99.5% of those costs, so just over $222 million, is paid under the MRO benefit. So our last slide here is a summary. So it ties it all together. We pulled the SUD data that was presented at the previous QFR to show that our total spend for calendar year 2024 on mental health and ABA and substance use disorder was $2,044,150,711. So investing wisely in mental health and substance use disorder services, we will continue to strengthen both the well-being of our communities and the long-term fiscal stability of our state's program. Switching gears a little bit, I'll be giving a financial update on the Pregnancy Promise program, and that program connects our pregnant and postpartum Medicaid mothers members who are impacted by substance use disorder, connects them with any type of pregnancy-related care that they might need, as well as services for mental and physical health needs, as well as unmet social needs. Just as a reminder, the Pregnancy Promise program is 100% funded through federal dollars. At the top of the slide, you will see the program's personnel time. And we'd like to put in a plug here that we are actively recruiting for a full-time nurse case manager position to help support the great work that this team does. A look back at 2025 shows that the actual expenditures were around $421,000, which is about $1.8 million shy of the annual budget for the program. That variance is largely driven by a delay in executing timing for our MCE contract amendments, which would fall under that external service expense category. So moving forward, that category would be much more aligned to the actual budgeted amounts. And then lastly, although not included in the slide, but just as important, there are a number of accomplishments that came from the money spent for this program. In 2025, we expanded the program from pregnant and postpartum members with just opioid use disorder to the broader substance use disorder. The team was also able to use these federal funds to provide childcare scholarships for children and the moms of the program. That allowed them to use those moms to move off of the voucher wait list. And then lastly, we did see a 99% survival rate of those enrolled mothers through 12 months postpartum, as well as a 94% rate of those moms sustaining recovery. We're really proud of the work that the team has done in putting those federal dollars to work.
Kat, do you have a failure to thrive number?
I do not.
Okay, for the kids?
I don't.
Are we collecting that, do you know?
I believe it is collected, yeah.
Okay, would sometime next week, just
No
send me the
problem.
failure to thrive number.
Sure, absolutely.
All right, I will complete our presentation by going through the Medicaid administration budget. If you think about the Medicaid administration budget and combine that with the Medicaid assistance budget that Kathy just spoke of, this is less than 1% of the total. Medicaid administration is typically funded at 50% federal and 50% state. However, there are some categories within Medicaid administration that are funded at higher levels. Those include systems, clinical quality, and program integrity. Right now, the Medicaid administration budget is operating 70% federal and 30% state dollars. Our expenditures are combined into three main categories. The first and largest being contract spend at 88%. We have staff salaries and benefits at 9%. And we have other administration, including IoT charges and state allocations at 3%. Now, while red is my favorite color, this is not the place you want to see it, except for that provider application fee line. So those are fees that we collect from providers applying. It's required by CMS, and that money is used to offset the cost of those applications. So that is all a positive benefit to us. Now we can talk about the other red. If you look at the external services expense, that's what we call the contract spend. And if you look at the middle column there in the variance, you will see that we have a positive variance of 23 million currently showing. That is due to vendor delay in invoicing. Some of those vendors are in this room now. Please send us your invoices. We do expect that money to decrease largely during the month of January, so you should see a different number the next time we meet. You'll notice in the last column that we show a $9 million variance here. If you look at the bottom chart in funding, we're operating at $8 million shortfall in total. If you look at the funding chart, you'll see that 5.6 million is federal. So once we provide the 2.3 million in state share, we will be able to draw down those federal dollars and balance our budget. So we still have some work to do to secure state share. Next up is the staffing. We currently are operating with 110 state employees, and our average for the year is 108. The last chart shows the major contracts for Medicaid administration. We have Optum Government Solutions that is operated by the FSSA Data and Analytics team. We have Maximus LCAR, or Level of Care Assessment, which is operated by the Division of Disability, Aging, and Rehabilitative Services. And the rest are managed within the Office of Medicaid Policy and Planning. So again, you will notice right now at this point in the year, we would expect about 42% of that spend to have been paid. So when you don't see that, it's generally a reflection of delayed invoicing. And that gives us a little bit less and a little bit more to get paid out.
That concludes our presentation, and we would be happy to take questions.
Thanks very much, Lindsay. First of all, for those who have not seen Lindsay in person recently, please take a look at her nails. They're truly a work of art.
We call them championship nails, so. Or natty nails.
Secondly, Kat, I wanted to go back to some of the comments you made about mental health spending. On my first tour of duty within Medicaid, that mental health number was much lower, as was the substance abuse, as the SUD number was much lower. So I think we have to realize, as we are managing the Medicaid program, and I will make this comment again, that in many respects, the managed care plans and Medicaid is far more of a mental health benefit than I think is generally understood. And we need to make sure folks know that and are integrating what we're doing at DMHA candidly more effectively with the health plans to treat those conditions.
Okay, we have one question. Okay, it comes from Chad Piper. Will the state amend the existing section 1115 waiver to reflect the program design outlined in SB 1 HIP 3.0?
Stay tuned to the presentation I'll be providing in a couple hours. So that's a tease.
Okay, thank you, OMPP team. We will reconvene here at 1:30 for the Division of Disability, Aging, and Rehabilitative Services. We now have the Division of Disability, Aging, and Rehabilitative Services. A reminder that if you have a question, you can either come back here and grab a note card and pencil and fill it out, or you can do it electronically by sending an email to askthesecretary@fssa.in.gov, and we will be reading those questions after the presentation. Thank you very much.
Well, good afternoon, everyone. I'm Kelly Mitchell. I'm the Director for the Division of Disability, Aging, and Rehabilitative Services. I have with me today our Associate Director, Kathy Robinson. Within the division, I think all of you are well aware, there are 4 bureaus housed. I have 2 of those bureau directors on the stage with us today. We've decided to approach this just a bit differently since we're large. We have the Bureau of Disability Services Director, Holly Wemsat, and our Bureau of Better Aging Director, Aaron Wright. But also in the audience, we do have our Bureau of Rehabilitative Services Director, Teresa Colazar, and our Bureau of Child Development Services Director, Christina Commons. So we are all here today united while we may not all be on the stage. Can we click to the next slide and go ahead and move through? So we're going to give you a real brief overview today of the former Division of Disability and Rehabilitative Services, DDRS. While we have created a new entity, DDARS, we won't be officially recognized until the new state fiscal year. So our appropriations and our financials are reported still in those old division structures. So I will report out on the DDRS, and then we will move into our programmatic areas of the 4 bureaus. We'll look at some overall division-wide metrics. And as we move toward the end, I'm going to have a conversation around our efforts toward waiver reset. If you would, next slide. And next. As you know, within the division, we serve individuals across a lifespan, from cradle to grave, if you will. Hoosiers who are experiencing a disability or aging and age-related disabilities, as well as those that might be at risk of developmental delay. What you see here is the financial summary for the bureaus, the 3 bureaus, and the administrative cost that were originally housed within the Division of Disability and Rehabilitative Services, or DDRS. Each of these will be highlighted within the specific bureaus, as well as you will see a Division of Aging breakdown later in the slide as well. What I would like to highlight is that we are projected at this point to close out the fiscal year well below our forecast, about 15 million below. So we have done an effective job of managing our operational cost. I will state this does not include our Medicaid spend. Holly will be addressing that separately, and then I'll tether onto that with waiver reset. But this is other social services payments that are funded through sources other than Medicaid, as well as our administrative and operational cost. And at this point, I'll turn it over to Holly Wimsatt.
Thank you, Kelly. Good afternoon, everyone. So the Bureau of Disability Services supports individuals, as Kelly mentioned, of all ages with disabilities. We have 8 field offices in the state. Let's switch to the next, please. We operate or administer 4 different home and community-based services waivers, and individuals are supported in a variety of community settings through those waivers. As you can see in the pie chart, the majority of individuals receiving support through the health and wellness and traumatic brain injury waiver are actually residing in their family homes or in a type of foster home settings like structured family caregiving. We continue, as indicated in the chart, to receive a significant number of applications for our services for individuals with intellectual and developmental disabilities. We are currently serving over 49,000 individuals in home and community-based services. And in the second quarter of this fiscal year, we have had almost 3,500 new enrollments across the home and community-based waivers that we administer. When we think about the family support waiver and the community.
Just to be clear, Holly, that does not include pathways.
That is correct.
Okay.
That is the 4 waivers administered by the Bureau of Disability Services. Thank you, Secretary Roob. That's the health and wellness waiver, traumatic brain injury waiver, family support waiver, and community integration and habilitation waiver. Here you will see on the pie chart the living arrangements for individuals being supported through the family support waiver and the CIH waiver. Over 76% of those individuals are residing in their family home, with a very small percentage of 7% living alone. In the table, you will see the active number of people supported on the waivers and the average authorized waiver budget for the individuals supported. I do want to stress this is what is authorized on the waiver. That does not include state plan spend, for example, like home health or anything like that. When we think about the family support waiver and we think about what's expended, it's about $28,000 average spend per year per individual when we consider what is expended on state plan and waiver. For the CIH waiver, it's roughly about $118,000 spent between state plan and waiver. For the traumatic brain injury waiver, it's about $99,000.
So Holly,
Yes.
if I may.
Oh, please.
It may be a point of clarification. Your slide references authorized budget.
Correct.
And you're talking about spend. Would you?
Yes, the slide is authorized waiver services only. It is not waiver spend. It is not total Medicaid spend. It is only what is authorized on the waiver. What I was sharing verbally was an actual spend, an actual average spend per year for individuals on the various waivers. So there's a big difference here. But the authorized is what individuals are authorized to receive on the waiver. Thank you. So for individuals to be eligible for Medicaid funded services through those waivers, the 4 waivers we administer, they must meet what we call level of care. That's nursing facility level of care for the health and wellness waiver and the traumatic brain injury waiver, and also, of course, that is also required for nursing facility placement. We have a statewide vendor that is our level of care assessment representative vendor, or LCAR vendor. That is Maximus. They complete nursing facility level of care assessments and issue determinations for nursing facility level of care. You will see the year-to-date numbers that they have completed for the purposes of home and community-based waiver services, and then for the purposes of nursing facility placement, often referred to as PASS-R, pre-admission screening and resident review. For the ICF IID, that's Intermediate Care Facility for Individuals with Intellectual and Developmental Disabilities, that level of care is required for the family support and the CIH waiver. And those assessments are completed by state staff or case managers on those two waivers for people who are active on the family support and CIH. We have rolled out new tools to assess that level of care. The pie charts that you see on the slide will shows the high percentage of approval, particularly high on the ICF ID applicants. It's almost 100%. So the new tools are rolling out, and we will be gathering that data and looking at that data and analyzing it now through August.
Can you explain which of these waivers does the special income limit apply to?
The special income limit applies across our waivers.
All four of them?
Correct.
And can you explain what that is?
That is an allowance. It is related to financial eligibility for the waivers. And it is when individuals apply for Medicaid, if they have a home and community-based services waiver, and we coordinate with our friends at Division of Family Resources, DFR, if they have a waiver, their income limit to be financially eligible for Medicaid is slightly higher. Well, not slightly, higher than what is required for financial eligibility for Medicaid without a home and community-based service waiver.
Thank you.
Thank you. I'm ready. As I mentioned, the level of care, nursing facility level of care is required for the home and community-based service waivers, health and wellness, TBI, also the pathways for aging waiver. It is also required for the nursing facility placement. The pie chart you see just gives an indication of how many of those assessments and determinations that are issued by Maximus are related to the nursing facility placement, which is signified by the PASS-R, about 44%, and how many of those are done with the purpose of home and community-based services. We have in current state nursing facilities historically have completed nursing facility level of care assessments for individuals seeking placement in their facility or seeking continued stay in their facility. We have rolled out a hybrid approach where Maximus will complete less than 50% of those nursing facility level of care assessments for individuals seeking continued stay in nursing facilities. And we are starting with 24 facilities throughout the state, and each quarter we will move to a new set of 24 facilities that will participate in this hybrid model. All of the 4 BEADS administered waivers have a designated capacity in the waiver documents, or slots, if you will, numbers of individuals, unduplicated count that can access the waiver according to the approved document. What you see here is the waiver capacity per BEADS administered waivers. We have reached capacity on the family support and the CIH waivers. The 787 that you see and the 218 that you see are slots that have had individuals invited to those slots. What that means is individuals have been notified that they have a slot if they get through and still want a waiver. and they get through the process of the financial and functional eligibilities for those waivers.
So Holly, does that mean can we go back? If I'm looking at the top row, the family support waiver, and it says the remaining capacity is 787. If I understand you correctly, though, there have been invitations extended that equal that amount. So
That is
unless individuals would either decline or do not meet some required step within the time frame, there would be no further slots available. Only those if they were rescinded or declined. Would
That is
that be
correct.
correct?
That is correct, Kelly.
Thank you.
These are our active participants on the health and wellness and the family support and the traumatic brain injury waiver. As you can see, we continue to increase the number of people we support on those waivers. We also have on the lower part of the slide, the wait list figures for each of those waivers. But you can again see when you look at just in 2025 and April of 2025, September 2024, we have continued again to add people into those services. Supervised group living or group home, that is our, the Bureau of Disability Services residential, facility-based residential option for individuals with intellectual and developmental disabilities. We have had 140 new enrollments this year thus far, which is more than how many the new enrollments we had this time last state fiscal year. However, we are serving fewer people. If you look at the total number of individuals supported in SGL. Much of that is due to the fact that we see a lot of movement through those supervised group living settings. It is historically has been a way to the CIH waiver. What this has done is utilized a lot of capacity on the CIH waiver for individuals coming out of those SGLs who may not be those individuals who are at the highest, have the highest level of need or the more complex needs. So we have taken some, recently implemented some processes and announced some processes to really take a look at, how do we ensure that as we have space available on the CIH waiver, that those spaces or those slots, if you will, are used for those with the most complex needs and the highest need. All right, this is our Medicaid versus non-Medicaid, the majority. I'm going to start talking faster because Kathy's prompted me. We have, most of our services are Medicaid funded. Real quickly, if you look at the CIH waiver, we support 18% of the population on the CIH waiver, but it accounts for 42% of the Medicaid spend within BEADS. This is all important as we think about, and Kelly will talk a little bit more about this later when we think about waiver reset and really how do we look at rebalancing to ensure that we're addressing assessed need. Our Medicaid expenditures, Kelly mentioned I would talk about this. You will note that we are over projections on the family support waiver and CIH waiver. This isn't because we are spending more per person, it's because we are serving more people. Again, we're at capacity on those waivers and it is showing in our expenses. Our financial summary, we are projected to come in slightly under budget. But other than that, things look good. So I am going to pass it to Erin.
Thank you, Holly. Good afternoon. The Bureau of Better Aging is designated as the state unit on aging under the Federal Older Americans Act. And within this role, we designate local organizations to serve as area agencies on aging, or AAAs, to address the needs and concerns of older adults and caregivers in their assigned counties. And the map shows the 16 different service areas across the state. The AAAs are involved in the majority of the programs that I'm going to talk about today. Our network receives about 67% of our funding through different grants and contracts. Most direct services are provided through local service providers, services that are really core to the AAA designation, such as case management, information and assistance, outreach, are provided directly by the AAAs. So Indiana Code was updated last year to include language about conducting a study to look at the map and the distribution of the AAA service regions. With 16 different regions, we manage 16 different sets of contracts, grants, relationships, entities. And this is really an opportunity to take a look at the structure that was designed well over 50 years ago. It is a multi-year process to make any changes to the map, which are outlined here. There are federal and state processes that we would need to follow to change the distribution of the service areas or the map, and then to designate organizations to serve as the designated AAAs for those regions. So our goals in evaluating the map are really to identify opportunities for increased administrative efficiencies, better support sustainability, and really ensure that we are positioned to address the evolving landscape of aging and long-term services and supports. So we are supported through various state, federal, and dedicated resources, and it is the combination of these working together that support the work that we do. I will be touching more on the individual programs as I go through the presentation. Our overall budget is over $151 million. Around 2/3 of that is federal funding that supports access to and the provision of home and community-based services. With our merger of the Division of Aging with DDRS and a reorganization of our staffing within aging, we are really focused on positioning ourselves to better support the delivery of services, the utilization of resources, to ensure that we are really maximizing service delivery and minimizing any variances. We are in the process of recruiting for some vacancies related to our reorganization, and that is contributing some to our variance in aging administration. I wanted to share that with the merger and with our realignment with the Division of Aging and DDRS, there's a projected savings of around $300,000 just in the administration between the two divisions. In addition, this merger is allowing for better coordination between programs and the consolidation of an IT system, which is projected to save about $3 million within FSSA. Next. So a variety of funds support the BBA home and community-based services, illustrated by the pie chart. Half is federal, a little over 1/3 is our state-funded services, primarily the Choice program. Then the remainder comes from local match and program income, which are primarily client donations. We directly served over 15,000 individuals through November, primarily older females who are low income, living alone with a number of risk factors related to independent daily living. The bar chart reflects the waiting list by the different programs, and we've continued to see an upward trend. You may notice that it appears that we are on track to provide less transportation services and respite services this year compared to last. That we think is a reflection of data entry timing, as well as the end of additional Older Americans Act COVID funds that have supported expanded services over the last several years. Through the AAAs, we support a variety of nutrition services with the goal to provide high-quality, person-centered services that promote health and well-being by looking at food insecurity, malnutrition, while also supporting opportunities for socialization. Through November, we served over 900,000 meals to about 13,000 individuals. And on average, through 226 congregate sites, we serve about 50,000 meals a month. The bar chart shows the distribution of home delivered meals provided by the AAAs through November, and it really highlights the differences between the volume and distribution of services amongst the different AAAs. Because of federal funding and grant processes, we are generally not easily able to or efficiently able to move resources around between services and the different areas. And this has contributed, we think, to waiting lists and some underutilization of resources. You will see what I was talking about here with the funding and projections at year end. At this point, we are projecting to underutilize some of our choice funding. We are working with the AAAs to operationalize some legislative changes from last year regarding the choice program to really focus more on prevention and Medicaid diversion. And we anticipate this will lead to a shift in some of the funding patterns that we've seen. Again, here we are projecting to end the year with some funds remaining. We receive around $42 million in Title III, which is the Federal Older Americans Act funds. We're projecting about $2 million unspent at year end. These funds, unlike our state funds, can be carried forward into future years. We'll talk a little bit about some of our programs that support access to services and information. Aging and Disability Resource Centers, or the ADRCs, are a primary door to access long-term services and supports. And with the transition to the Level of Care Assessment Representative, or LCAR, that Holly discussed, we revamped the ADRC contracts this year with an increased focus on quality and outcomes. The AAA or the ADRCs have provided over 65,000 information and assistance one-on-one contacts through November. There were over 12,000 referrals back and forth between the LCAR and the ADRCs, and over 1,200 individuals received Medicaid application assistance. You can see we are seeing a lot of variability in the cost per person across the network, which we are in the process of further exploring. We think it could be a reflection of the intensity of the support that's provided, how the ADRC staff are documenting their interactions, how we structured the rates, or it's likely a combination. The Dementia Care Specialist Program continues to engage with local communities to engage dementia-capable care and services for people living with dementia and their caregivers. And nearly 10,000 participants were served in Q1, which is the most recent information we have. In Indiana, the Alzheimer's Association projects about 11% of individuals age 65 and over have dementia, specifically Alzheimer's. That number is not including the other dementias, it's just Alzheimer's. And about 80% of all those with dementias are living in the community. And this program really aims to create supportive local communities to prepare for and serve this growing population, recognizing this important role that local communities play in the system of long-term services and supports. The engagement noted here reflects trainings provided to Indiana businesses, sheriff departments, emergency medical technicians, college students looking at pursuing careers in aging, really building capacities in those communities. I also want to mention the Yellow Dot program. This was an unfunded mandate passed in legislation last year, creating a notification system for first responders. A yellow dot, pictured here, is placed on participants' vehicles, indicating that there is critical medical information included in the vehicle's glove box. Through a partnership with the Indiana Association of Area Agencies on Aging and AARP, 15,000 of the yellow dot packets have been distributed through the AAAs and are available through the AAAs and will be distributed to all local BMV offices as well, thanks to AARP's coverage of the printing costs. And outreach has and will continue to occur to ensure that first responders know to look for the yellow dot. Yeah. 2 minutes, okay. SSBG, we're on track. Next. Also this one on track. Next. Sorry. That's okay.
Real quickly, just the Money Follows the Person program. We just have a summary here indicating the enrollment. We continue to get requests for Money Follows the Person or MFP, and we continue to process those requests. So I will pass it back to you, Erin.
Okay.
The MFP financial summary, you can see nothing alarming there. We just continue, again, working towards enrollment.
The RCAP program is a state-funded program that supports low-income vulnerable Hoosiers. We have been seeing a decline in providers and facilities that participate as well as participants. However, effective this past January 1st, I guess the beginning of this month, the RCAP rates were increased for the first time in over a decade. So we are hopeful that we will see a reversal of that trend. Next. And with the rate increase, we're anticipating being all set. Next. Regarding our elder rights programs, in July, we transitioned the Adult Protective Services program from a prosecutorial model to a social services model, including a transition to a single statewide vendor. We have really, in this last 6 months, seen an increase in efficiency within this new model. We have maintained a staffing rate of above 90%. There is actually less staff with this new model, yet the average caseloads are still within the best practice recommendations of 25, and caseloads have remained consistent between the two models. With the long-term care ombudsman program, which advocates for residents' rights in nursing facilities and licensed assisted living, the second quarter, the top 3 resident complaints that were addressed were resident care, individual choices and rights, and discharges and evictions. With Adult Protective Services, we are showing a variance right now. We think that is a reflection of a lag in claims coming in that was not updated in the forecast. And then long-term care ombudsman on the next slide. We are on track and any remaining funds can be rolled over.
All right. Good afternoon, everyone. As Kelly mentioned, I'm Kathy Robinson, and I am the Associate Director for the division. And as she noted at the start, we are taking a bit of a modified approach for today's presentation, and we are focusing on BDS and BBA for the majority of the QFR today. And so I'm going to hit the highlights for the Bureau of Child Development Services and the Bureau of Rehab Services. So I get the delight of pretending to be Christina Commons and Teresa Colazar. This also signals the middle of our presentation. So thank you for hanging in there for as long as you have. I'm going to just touch on some key areas for the Bureau of Child Development Services and BRS, and then I know Kelly is going to finish us off with some additional information about waiver reset. So I just want to speak to this slide very briefly because we typically provide this summary information of the total number of children that are being served by county. This is Q2 of state fiscal year 2026. In addition, we also pair that with a an additional infographic of the state, which reflects the percent of children served who are 250% or below federal poverty level by county. And we do that just so that we can better reflect or provide some context about the needs of the folks that the First Step system is supporting and where those resources and services are being directed toward. This slide, I will just highlight a couple of pieces of information that I feel like may be important that I know that Christina Commons and Teresa Colazar are here in the room today as I'm pretending to be them up here. So if I say anything totally out of sorts, give me the signal. But I want to just highlight the number of children referred in the quarter, which was over 7,500 children. The number of children served in the quarter, which was over 16,000 children, and the number of family visits provided in the quarter, which was over 180,000. And then with that, there's the exit data, which I know the First Steps team monitors pretty closely as a means to assess quality and outcomes for the individuals that are being supported in First Steps. So you'll see across the top the total children who are exiting in the quarter, and that could be exiting for a variety of reasons. They may not be eligible, they may not have decided to enroll for whatever reason, and other reasons that they may have exited are then further broken down below. So children transitioning to preschool special ed, they're leaving the First Step system and moving into preschool special ed. There's also 770 children who exited in the quarter with having met outcomes. So the developmental milestones were on track for those individuals, and children withdrawn by parent before outcomes met. And that would just be leaving the program for a variety of different reasons. I know First Steps also does a survey to try to narrow in on maybe why they might be exiting, but that's just a summary of those exits for this past quarter.
So the services delivered slide, those aren't unique. I mean, you could both be receiving developmental therapy, physical therapy, and speech therapy. Correct?
Yes.
Okay.
Yeah. So there's a combination of folks that could be just getting one of those services, but then kids could be getting multiple in that chart. Thank you. And then this is the slide that Christina has regularly shared regarding the funding streams for First Steps. A couple of things I will just note here, particularly the family cost participation, and you'll see a decline or a dip in the visual there regarding the receipt of family cost participation. I think the First Steps team identified in December there was a bug in the system that would actually not allow families to make family cost participation payments. That has since been addressed. In January, family cost participation payments are back to what we were seeing in July and August. And I think First Steps has already received over 2,000 payments, kind of catching up for the bug that was identified in the system. So they're getting back on track. I just wanted to explain the notable difference there in the FCP chart. Looking at the Bureau of Child Development Services financial summary, there is 2 to 3 grants open for the first half of every year, which is why you're going to see some of the budget differences throughout the course of the next several quarters. BCDS currently is projecting to be 7.9 million under budget, and that total that you see is going to fluctuate due to just the recoupment processes that operates in First Steps. There's always kind of a rolling recoupment effort, if you know the kind of pay and chase model that the Bureau is operating within. So that number is going to continue to update, but we're feeling confident in that projection right now.
So I always like to highlight this. That projection to be that far under budget is in regards to the state appropriation. So the effective utilization of those multiple sources of funding, Medicaid, family participation, and private insurance, have reduced the reliance on state public dollars. So again, a very effective funding model.
Thanks, Kelly. All right, so moving into becoming Teresa Colazar for the next few minutes. And wanted to just touch on this slide. I won't read it to you because we've presented this in a few different QFR sessions in terms of what BRS provides, but I do just want to highlight the map for January of 2026, and those are the open VR cases by county. So that's just the VR portion of BRS. And just noting again that the largest source of funding for BRS is federal formula grants with the required state match.
Are we maximizing the amount of federal money that we can draw down in this program?
This is a really, I was not expecting you to ask this question.
You might be surprised.
Very surprised by the question. So we are not, but you did kind of do me a favor and set me up because I know that Teresa and the team have an open bid out currently, and I won't go into the details of it, but a lot of that, I think, is an effort for BRS to be better positioned to potentially leverage some additional federal dollars for the purposes of that. So if you are a fan of the IDOA website, you can go out and look at that procurement opportunity. I won't go into a ton of detail, but it does help us identify ways to build capacity with local units of government to help bring some dollars to the table that will help us leverage those federal funds. So thank you for the question again. I'm going to just hit the highlights here. One of the things that I am going to shine the spotlight on Teresa for just a minute. Last week, I believe, we had our division advisory council. Teresa was there and presented some information on the Indiana Commission of Rehabilitation Services annual report. That report is on our website, but it's also a summary. Teresa does a great job of summarizing that in the DDARS Advisory Council, and it's on our YouTube channel, so you can go check it out. The reason I highlight that is because there are several specific stories that the team has identified, really reflecting really effective coordination with vocational rehabilitation, and the resulting effects of that being individuals with disabilities achieving integrated competitive employment outcomes that are truly meaningful work and meaningful jobs in the community doing things that they want to do. And we'll probably talk a little bit more in future sessions about some of those stories. But I just wanted to highlight that. So these numbers certainly reflect the team's efforts in this space. There have been some changes that Teresa and that team have been implementing as cost reduction strategies, and that's going to reflect in some of the budget information that I talked to here shortly. But I just want to note this, certainly some of the flattening out of the quarterly service payments during the latter part of state fiscal year 25, and now some more notable progress during the first part of state fiscal year 26. Really working toward a more sustainable level as aligned with the current fiscal resources that BRS has.
Would you mind flipping back to the last slide?
Mm-hmm.
Yeah, and maybe the next slide will answer my question. But the mental health diagnosis, are we connecting that into any of the CCBHCs or CMHA or community mental health centers? Or is that usually a mental health is a secondary diagnosis? Well, that says primary.
Yeah, so we do have some. Teresa, I know you and your team are working with Division of Mental Health and Addiction on some of the, there's some intersection there with the mental health side of things. It's not one for one, but there are some, I'm looking at Teresa for confirmation if I'm saying anything crazy. Yeah, follow-up convo noted. We'll speak here just briefly to this slide visual that you can see the bar chart across that really highlights the services that VR offers and the utilization of those. The most being those employment services, and the employment services has been further broken down over here on the right here, so that you can see what kind of services we're talking about when we talk about employment services. Teresa and the team have done a great job of really shifting a higher portion of their funding to more direct job placement activities in lieu of some of the job discovery and some of the job exploration areas. And so that work will continue as a means to sort of help with that successful employment placement effort overall. But you can kind of see where those dollars are, the majority of those funds are being used and how they're being used today. So summarizing the BRS program metrics, you can see here this is a state fiscal year 26 quarter one comparison with the numbers in the far right. The number of VR applicants, the total enrollments, and the number of VR cases closed. There's also a percentage of eligible participants who are on service plans and the closures exiting with employment, as well as all of the other VR closures of reflecting those who are exiting with employment as well. Across BRS, approximately 30,000 individuals with all types of disabilities receive services from BRS programs at an average annual cost of less than $4,000 per individual, as far as how those funds are being used per person receiving those services. We'll touch on this financial summary for BRS. On target overall, there are some final steps for BRS for a few office moves due to leases that are expiring. So when those come up, we look at space availability and whether or not we can save money by moving locations. And so that's a reflection of some of those move expenses. And then BRS is continuing to prioritize only the most essential vacancies to fill. And looking at how best to fully utilize the staffing personnel resources. With that, I'm going to turn it over to Kelly Mitchell, who may also have red fingernail polish on today.
I do. Lindsay made me promise, you know. Mine aren't quite as artful as hers, but I am wearing red. I wanted to spend the last 10 to 15 minutes of our official presentation talking about waiver reset. If any of you had the opportunity at this month's DDARS Advisory Council, I gave a rather extensive overview of waiver reset. I think it was about an hour and a half, questions and all. That is recorded and it is available on our YouTube channel. So I would encourage you to look there if you would like more granular understanding. What you see before you is a list of the initiatives that we had set forth in DDARS, and for many of those, you will note they say completed or we're looking at completion in the next month or so. We are now really focusing our efforts on waiver reset, so if you would, next slide. And I want to speak to that. There is some misconception about what waiver reset is and what it isn't. And so this is a great opportunity today. It really is an opportunity for us to rebalance, if you will, our approach to long-term services and supports. Obviously, within our division, we manage Medicaid waivers. But that, as you have heard throughout today, is not the only way that we support people in long-term services and supports. It is a combination of Medicaid state plan. There are long-term supports available there, Medicaid waiver, and other community supports and funding sources, as well as informal supports. Historically, we have operated in silos. And I think Secretary Roob, to your credit, today and throughout your most recent tenure, you have drawn attention to that. Oftentimes, Medicaid waiver has operated in isolation, as has Medicaid state plan. And we are not looking at how do we support the need of individuals in those long-term services and support. So how do we work in a collaborative fashion? How do we look at this holistically? Waiver reset is one piece of this, and it will fit, and Secretary Roob, I believe you will be speaking to this later, into an overarching outcome desired by FSSA to improve our care coordination and coordination of services and supports. So what do we know? Obviously, as you've seen, particularly in our presentation today, our demand is exceeding current capacity. So we must find a way to create a more sustainable model. We also need to focus on supporting needs versus a system that is focused on diagnosis. How do we better leverage and coordinate supports? I appreciated, Secretary Roob, that you question within the vocational rehabilitation how we work with mental health. I made a note as I was listening today, and I believe it was in DMHA, and they were talking about supporting transportation. And I said, wow, we support transportation in waiver, in state plan, in VR, in all of these programs. And I'm like, I wonder how much money we spend on them, and is there a more effective way? So that's what we're talking about in rebalancing and resetting. So how do we do that better? And finally, how do we simplify what we're doing? It's confusing for those who are accessing services. It's confusing for those that are trying to manage and oversee those programs. So how do we simplify? How do we look at not only the array, but the services and the processes to access, implement, and monitor those services? So first, let me clarify one point. Amendments, recent waiver amendments, do not equal waiver reset. Can I say that really loudly to the people in the back of the room? The recent and coming waiver amendments do not equal waiver reset. There are some pieces within those amendments that are putting things in play that allow us to move toward waiver reset. Those would be the new level of care assessment tool, an objective standardized tool to determine eligibility for individuals with intellectual and developmental disabilities. We've already done that for the nursing facility level of care, the Enter-I suite. Now we will be launching that for those assessment tools for the waivers that have traditionally focused on intellectual and developmental disabilities. The other piece of those amendments that sets the stage and allows us to move to a new model of coordination, a system of support, is the change in case management. There is a RFP out now, but moving toward a selective contracting model across all of the waivers that are housed currently within the division. That will allow us to have a strong relationship of quality case management entities that can support individuals and those that support those individuals through any transition associated with waiver reset. So two very crucial foundational pieces, but not waiver reset. So you see this timeline, and it recognizes there's waiver updates, there's waiver reset. Many of you may have been involved in the last calendar year, in the last quarter, between October and December, some engagement that we had with stakeholders, providers, families, individuals, advocacy groups. Golly, was it nearly 2,500 people that we engaged with in that 3-month timeline? And so we traveled around the state. We also had virtual, I think, opportunity for engagement. We had some one-on-one interviews, talking to folks that are using waiver services, that support people, that advocate for those long-term services and support. What do you need? what's working, what's not. Don't tell me what not to do with the current waivers, or what is it that we need to do, because we know our current system isn't working the way it was meant to. It was a system that was designed decades ago and, quite frankly, designed for adults only. And it also was designed more around an institutional model as we were coming out of institutions. And so we gathered that feedback, and you will soon see the published results of that. I believe there will be a video and some summary, so we will share with you what we heard. We are between now and August of this year, we will be working with our consultant, Human Services Research Institute. Once we've been utilizing this new level of care assessment tool, this new Enter-I suite for IDD folks, they will be looking at the data, the population that we currently serve on all 4 waivers. They will be looking at the waiver services as well as the long-term services and supports that people are receiving on state plan. And from that, we will get a picture of, if a person is this age and lives in this setting and has X, Y, and Z, this would be a typical model service mix. That's going to inform us as a state and our stakeholders. What should this new model look like? What should this new array look like? So the outcome for us is, one, that we would identify these model service mix that give us an objective framework so that we can work across all those funding sources. And if Kelly Mitchell is seeking long-term services and supports, you could look at me and say a person that has the typical needs, that is Kelly's age, that lives in this setting, would typically require X, inclusive informal supports. And we could use that for Medicaid state plan as well as waiver to look at how we design that. Separately from that, then, we say we have X amount of dollars. What is the legislature appropriated to us for Medicaid? And then within that, what do we have available for waiver? And we will establish budget tiers that will help us then create a sustainable system. The long term of this is, once we have that data, we have folks on a waiting list. I'm going to look right at you, Secretary Roob. I could look at you and say, Secretary Roob is on the waiting list for services. He's this age, he lives with his parents, blah, 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 has these needs. We could project that the anticipated cost of supporting Secretary Roob is this amount. And we can do that for the folks, and we could then project what his future state needs. So it helps us not only manage current, but how do we plan for future with real-time data. So we will be working on this over the next year. We are engaging with what we refer to as a community advisory board made up of advocates, associations, individuals, obviously, family members. Obviously, there's internal engagement. And this isn't just a BEADS thing or a DDARS thing. This is FSSA engagement. We are working with our partners in OMPP, DMHA, really looking at how do we create a better system. But our target is sometime, it's target, right? We don't have an exact date because we have to figure all the things out. Moving towards sometime in 27, we would have that model framework. But when we are ready to implement, there would be a period of transition. So all of this will continue to be communicated as we work forward. But know that we will share as we progress through these steps, and that the ultimate goal is to have an improved care coordination model that allows us to budget with certainty and create a sustainable system working within the fiscal constraints, the fiscal environment that we are given. Did I cover all the pieces, Kathy?
So, yeah.
With 2 minutes to spare. So the last slides in this deck are really appendices. I will let you peruse those, but you will see the DDRS admin financial summary. That is just a breakdown of the administrative costs associated with that former division as well as the Division of Aging. You will see a listing of both contracts, and then there are some smaller aging financials there for your reference. And that concludes our presentation. Happy to take questions.
Okay, we have a few questions. Just quick reminder, if your question is not read here, you will receive a written response. First two questions are from Kelly Tungate. Question for Holly Wimstat. Can you clarify on slide 165 waiver capacity what the true remaining capacity is for the H&W waiver? I understand that there are invitations that have been issued that remain in pending status. Does the 218 number suggest that for the invitations that have been issued and are pending, only 218 waiver slots remain for those individuals?
Sorry, we're going back to the slide, maybe?
Well,
not.
I was trying to find it. Yeah, go ahead.
165, if that helps.
I got there.
I don't want to step on Holly's parade, but I deal a lot with the health and wellness waiver and the waiting list. The actual slots that we had available to issue at the onset of the waiver year, which begins in July, have already been issued. So there was a turnover, right? Those that were vacated from the prior waiver year. So we released all of those in July and August. So what this references is there are invitations out there. These are open. What this doesn't reflect is we are continuing to release slots every month. If you refer to the FSSA waiver waiting list dashboard, we release invitations every month. Just this month, in January, we released 300 invitations for health and wellness, and I think 603 for pathways, or I think it was 603. It was slightly over 600. So when people decline or they are rescinded for not meeting timelines or requirements, we immediately put those back into the system. So it doesn't mean there won't be additional invitations, but what this means is as far as actual open, vacated invitations, they have all been extended at this moment.
And just, I don't think we operate like an airline. So we don't invite people off the wait list unless there's an open slot.
Absolutely. We cannot duplicate an invitation to a slot. If I've invited Kathy Robinson, I can't then invite Holly Wimsett just because I haven't heard yet from Kathy Robinson.
Okay, follow-up question. Can you explain the difference between slots assigned as of 12/31/2025 and remaining capacity as of 1/20/2026?
Sure, the slots assigned mean there's actually someone in that slot. So the slot is, the person has gone through the invitation process and is moving toward active. So they met the requirements to get through that process.
Okay, our next questions are from Kim Burns. This one has a lengthy preamble, so bear with me. These QFR presentations include a number of charts with many helpful numbers. On any single chart, there are comparisons of actual spend versus forecast. And in most cases, DDARS is below forecast, which is great. What about year-over-year growth or contraction?
Most of what you see on these DDARS financials is what I would refer to operational or social services. We can compare and often do compare year over year. I will take this as an opportunity to address the Medicaid we could go back to that slide. I'm not sure what number, it was later in the beads. While you don't see a variance, the last column on the Medicaid spend is the prior year, I believe. Yes, state fiscal year 25 actual spend. And you will see, yes, we are well over the projection for year to date. But if you do the math, the variance column isn't over here. We're well over the spend from the prior year for those waivers. Again, that's attributed to, you saw there aren't any slots remaining. The volume has increased dramatically over the past year. So the number served has grown dramatically over the past year.
And one of the other things I'll note is another example I think would be for BRS, where it looks like they have, they're going to come in under budget. That is really an intentional effort on that Bureau's part to ensure there are what you would call carryover funds, because they are anticipating needing those funds in order to essentially meet their budget limits within the next year. So you're going to see some anticipatory planning on our part to anticipate and just plan for some of those other costs.
In previous presentations, Secretary Roob has indicated that a goal is to solve for 2%. In other words, to keep growth under 2%. What is the current projected fiscal year 26 growth for DDARS HCBS services? Is it staying at or below 2%?
I don't know that I can address this at this point. I may defer to Secretary Roob as you, I can, but I think I might do it disservice.
That's we'll get back. That's a good question. We'll get back to you on that. Unless Paul, you know off the top of your head. No, if Paul doesn't know off the top of the head, nobody knows.
If Paul doesn't know, none of us.
So the goal is agency-wide a 2% number,
Yes.
right? So I really look at the agency. And your point is, well, you're an awfully large agency. Maybe you should look inside. And you're probably not wrong. So thanks for the question, and we'll figure that out.
How do you pick which member gets the assessment and the waiver? And can you explain the time it takes in order to get on the med waiver?
So different waivers have different, what we call reserve capacity. So individuals must, though, meet financial and functional eligibility to access a waiver. And then when they are able to actually begin waiver services, again, depends on if they meet reserve capacity or if they are on a wait list that is first come, first serve. So it really, again, we'd need a little more specifics on that question to give a very specific answer.
So one of the things we found, and I don't know if this is still true, but we were inviting people off the waiver wait list and giving them 365 days to sign up, and only about 40% of those people were ever eligible to receive waiver services. So that meant that 60% of the slots were being unused. So that we changed it to 180 days. We're making some other changes in terms of how you get on the waiver wait list. You know, it used to be you just said, someone asked you, do you want to be on the waiver wait list? Sure, I'll be on the. It's like being on the Colts season ticket wait list, right? There's not much to do to get on it, but once you have to buy those season tickets, those are pricey.
Yeah, Secretary Roob, I'm really glad that you made that observation. And I think you're seeing some of that highlighted in the fact that we actually are actively serving more individuals. So previously, particularly on the CIH and FSW, I'm going to be very transparent here. Holly, you correct me, but there may have been individuals that were holding slots more than a year.
That's correct.
So people would linger, and so these slots then weren't available. And so what we really saw was an underutilization of the capacity that we do indeed have. So while you hear, hey, we are at capacity, these numbers reflect we are actively serving more Hoosiers in need. If I go back to 2014 and only look at the folks with intellectual and developmental disabilities, back in 2013, 2014, we were serving around 14,000 individuals with intellectual and developmental disabilities. You saw the numbers. Today it's 35,000. So we have made great strides, and that is why waiver reset, this rebalancing, is important. How do we sustain that? And obviously, how do we meet the demand, the needs that exist?
This next question is from Jason McManus. What is the status of determining which persons served on the various Medicaid waiver programs who are dually eligible for Medicaid and Medicare, and how can providers participate in this process to ensure that all federal dollars are being appropriately drawn down to offset Medicaid costs?
So yeah, I'll speak to that. Some of you may know, we were engaged for the past several months with some technical assistance around this, and really looking at particularly dual eligibles with the IDD population that oftentimes is a group of folks who may not realize that they may be eligible for Medicare. And so we have been partnering with our friends in OMPP to coordinate on some activities that we can here soon engage in to help us identify not just who is eligible and may be dually enrolled, but who is potentially eligible and has not, and that we can do some additional outreach with them, particularly with the support and engagement of the waiver case managers, who may be able to do some additional follow-up so that those folks understand why they might want to enroll in Medicare if they're eligible.
And if I might just layer another piece, I'm going to circle back to waiver reset, waiver rebalancing. One of the tenets of this, and one of the pieces, is that we really want to get to outcome-based. How do we incent the outcomes that we want? So you could say outcomes-based, value-based. And for those of you that are aware, I mean, the current RFP that's out, you will see that reflected in that case management RFP, that we are beginning the journey toward value-based, contracting, enrollment. So how do we incent? And one of those things that we would eventually want to look at is, are we encouraging and supporting that dual enrollment? So that's a great question.
Okay, that's it for questions. Thank you, DDARS team. We will return at 2:45 for Secretary Roob's much anticipated presentation.
Again, thanks to Paul, his team, all the division directors for really putting together a great product to articulate kind of where we are, and part of Governor Braun's radical transparency. So you know what we're doing, and you can help us plan, because we don't provide very many services. In fact, the only services we really provide are at state hospitals and with state employees figuring out how to do eligibility. So we're very grateful to the provider community and want to continue to work hand in glove with you as we face the many challenges in 2026 and beyond. So I'll come back to this chart a lot over the course of the next couple of years, honestly. I think you kind of can figure that one out, right? Hopefully, without me explaining it, but if you can't, I'll explain it anyway. Had we never had COVID, and had we had, candidly, a growth trajectory on Medicaid that would, as the governor says, would be responsible growth as opposed to COVID growth, we're about here now, right? And we're gonna be at 2%. But when we get out here, that normal growth is going to collide with that 2% growth, right? And so over the course of the next couple of years, we need new care models. And that's one of the things that we just talked about, was a new care model for waivers. to manage that cost growth trajectory. So we'll talk a little bit about the processes that we're using this year to begin that discussion. But first, I want to thank the people who helped to get us where we are today, and that is a $465 million projected return to the general fund, well beyond what I think most people anticipated. Had I stood up here a year ago and said, we're going to take $465 million out of the general fund budget, I don't think many of you would have believed me. But those dollars will be repurposed for education at higher ed and at K through 12. So thank you for helping us accomplish that. We started certified community behavioral health centers, and so that's an experiment, right? Early returns look promising. Need to continue to work on that and figure out when and how, if, when, and how we're going to expand that to the rest of the state. We've got 340B pricing reform that we passed. That'll go into effect sometime later this year, which will again help our budget out significantly. And we have a rural health transformation program award that you'll start to see those dollars flowing out here in the next couple of months. We were kind enough to be joined earlier today by my colleague in that. Dr. Weaver was here, and so we worked through and got an extra $6,900,000 more than we anticipated. That's really about the most any state got. Ohio, by the way, a much larger state, got $200 million. So just put that in some perspective for you. We rolled out our SNAP Healthy Choices program, which says food stamps or SNAP benefits will not be available to be spent for candy and soda. And we tackled the challenge of ABA therapy. You've all seen that, you all know what the growth rate trajectory has looked like for ABA therapy. Kathy talks about it at every one of these meetings. We think we have a plan in place that will make some minor reductions in reimbursement. You'll be happy to know we're going to 6 to 4, not 10%. So I think Representative Green knows that today. And we'll submit that state plan to CMS. So 2025 was the end of the beginning. It is not the beginning of the end, right? We have a long way to go. In many respects, the ship, the FSSA ship, it never comes into dock, right? We're constantly dealing with the next challenge. But what are those challenges that we're going to deal with, and how might we approach that in the upcoming calendar year? Well, you saw this chart earlier today, for those of you who are here. I think this is, I just took Kathy, my goal in life, I tell the governor all the time, my goal in life is to be the America's greatest policy plagiarist. Apparently it extends to slides. So you've seen some sliding here in home and community based rather in attendant care. You know, look up, this is 60 hours, right? That's 60 hours. So that's a positive, right? we were starting to control that, though, to be candid with you, once somebody starts at 60 hours, it's awfully difficult to roll that back. You've created a dependency. So the key here is not to create that dependency in the first place. But what we've seen, though, is a corresponding growth rate in pathways in home health expenditures. Now, it's not as much. We're still ahead of the game, but we need to be careful of that we're just not moving the water in the balloon from one side to another. Now, back there somewhere is a water balloon that I was actually going to try to use as a prop, but they told me I was out of my mind. So it's another issue that we have, and that's federally qualified health centers, right? It is, to me, I mean, if you look at this, I recognize that this is the law, right? This is there's nobody that is going to, believe it or not, there's no one going to jail for this. But it is, from my perspective, fundamentally unfair that Shalom Health Center is getting less than $200 and that Meridian Health Services is getting more than $600 for what amounts to the same service. And when you chart the, and then when you chart, and I haven't used this graph today, but if you look at quality and cost, they are completely unaligned, right? We have a chart, which we will eventually show you, that looks at quality and cost, no correlation whatsoever. I told some of you I was going to spend some time on the family and support waiver on some for us, and I'm really glad Kathy did a great job. Not Kathy, pardon me. You did a great job. We're walking through waiver reset today. But let's look at the state plan, right? Because waiver, most people, when they think about waiver, they think about the big blue piece here, right? The big blue piece. They don't think about the state plan services. So I'm going to pick on family and support waiver, the family and support waiver. The reason I'm going to pick on that waiver is because it's a fixed cost waiver. We know we know that the most you can get is $27,000. The most you can get is $27,000. So I asked the data team, our data team, to pull together the top 10% of each of these waivers, right? As you might imagine, they're hugely different, right? The lowest to the highest is hugely different. But I just wanted to look at the top 10% of the family supports waiver. The family and support waiver, the top 10% total spend is $299 million for the top 2,449 people on that waiver. The waiver itself, because it's capped, the most it could be would be $80 million. That means for 2,500 people, we have a planned spend of $230 million. Now do the math in your head, and what's that on a per member per month basis? So today, we have nobody managing that spend, right? Well, after we're done with waiver reset, we will have people managing that spend. I don't know how we're going to do that yet. Luckily, a lot of you are smarter than I am and can help tell us. But we can't be spending that kind of money and not know what we're spending it on. So I won't go back through this again. She did a much better job than I would ever do in terms of talking about waiver reset. We also want to make sure that people are aware of the mother of all procurements. The mother of all procurements. Some of you are old enough to recognize that that's actually the ELO, the ELO. But actually, the people who pulled this up, they'd never heard of ELO. But we're going to be in August of this. Our goal is in August of this year to put out the Healthy Indiana Plan, the Hoosier Healthwise, the Hoosier Care Connect, and the Indiana Pathways for Aging. That's a total of about currently 1.45 million covered lives. We're putting that out in August, and we're looking at starting these new plans on January 1st of 2029. So wrap your head around that. I'm going to talk a little bit about mental health services here. And you saw this, again, you saw this slide earlier. I think this was it in yours or in theirs? Yeah, okay. Kat had this slide, right. So this is mental health spend, and it really, and none of us knew how much we were spending in mental health care in Medicaid. And I'm embarrassed to tell you that, but this is mental health and addiction. It wasn't this way on my first tour of duty, right? It wasn't, we weren't spending nearly this much, but we are now, and hopefully we're spending it we're doing some good with it, but we really need to integrate our ability, our mental health care spending, and put a light on that in Medicaid. And also, not just mental health care spending, but addiction spending. A lot of this is on addiction spend. And so we need to do a better job of focusing on that. Not just because we think there's probably some ability to save money there, but I'm not sure that we're getting the value for what we're spending. So this happened because we have because the 1115 waiver for HIP and the Indiana Medicaid program supports substance abuse disorder program. It didn't, when I was here before, we didn't, right? So to be honest with you, when I got back here, I missed this, right? Until about 6 months ago. I think we should, I'm not saying we shouldn't do that. I'm just saying that we need to focus on it. And when we started it, I don't think anybody anticipated that we would spend this much money on addiction inside of Medicaid, not inside of DMHA, inside of Medicaid. And we lack quality and outcome metrics. So some of you have seen this slide before. I'm going to talk a little bit about Indiana's healthcare challenges now. We have high hospital prices, and we have substandard health outcomes. When I was here last time, I used to say that we were buying a Cadillac and driving a Chevy. Well, today we're buying a Cadillac, and I'm not quite sure what we're driving. Marcus put that up there. I have no idea what that is, but
it's a Soviet automobile.
Yeah. So I'll get to, so we had a question earlier about what we were doing with HIP 3.0, right? So you're going to get the long version of that answer. So I'm going to go back in the Wayback Machine, back into the early 1990s when I was at Health and Hospital Corporation. And if you wanted to get an appointment at, if you wanted an appointment, a primary care appointment, you went to Regan Street. Some of you may remember this. You went to Regan Street and you were given an appointment at either 8 o'clock in the morning or 1 o'clock in the afternoon. And you just sat there until your number got called. So a guy by the name of Dr. Joe Mamlin and I felt that that was not really the best way to deliver care to the indigent population. So we built a number of community centers around Indianapolis. We created the IU primary care group, and all to support something called the Wishart Advantage, which was something like a insurance product that we were able to provide to indigent residents. Now, at the time, the indigent population, and indigent's a word that you don't hear anymore, right? You don't hear the word indigent anymore, but the indigent population in Marion County was about 25%. I mean, it was really high. So we created this product, and what we wanted to do with it was begin a process where we would enfranchise the individual to care rather than entitle the institution. What we said was, let's give that person a card and let them go to different places and choose their own doctor. And that worked pretty well. For a proto being early on, and then when Governor Daniels was in office, we started and with the help of Pat Miller and Charlie Brown, we started the Healthy Indiana Plan 1.0, right? And that program was designed to do exactly what I just talked about, was to give real insurance, real Medicaid, paid at Medicare rates, by the way, to individuals who didn't have health care. So they could have choice in terms of where they went to get their care. And that worked pretty well. What we found in that population was that the majority of those dollars, not the majority, the number one use of those dollars was prescription drugs. Because we were able to take chronically ill patients and begin treating their chronic illness, and they were able to go to work in ways that had never been the case in the state of Indiana before, and frankly, most of the country. And then Governor Pence decided that he'd take those ideas and use and create HIP 2.0 using a state plan amendment covered with an 1115B waiver on it. And that worked relatively well. You had some responsibility. The individual had some responsibility. The state would reduce what you paid if you had carried out some healthy behaviors. Well, that was fine until the pandemic. The pandemic came along, and for understandable reasons, it basically shut down HIP, and it just became an insurance product. And just as the state was going to turn that back on, you had a lawyer, you had Rose versus Becerra, which essentially ended the Healthy Indiana Plan and turned it into a Medicaid expansion. Now, there's no possible way that the Indiana General Assembly would ever have, or any of the governors would ever have approved a straight, flat expansion of Medicaid. But that's what Rose v. Becerra did for us. So for the last year, we've been working on what HIP 3.0 might look like, right? And the big, beautiful bill happened. As my wife says, Indiana needed a hip replacement. So what you'll see over the next month, we're going to have a fairly vocal debate about what that HIP program ought to look like. And it'll be in HIP 3.0 and Senate Bill 1. Some of you have seen Senate Bill 1. I encourage you, if you have not seen and thought about Senate Bill 1, I would encourage you to do so. And go across the street and talk to people about what you think of Senate Bill 1 and how it might be improved, if at all. Some of you may think it's perfect just the way it is. But the work requirement, or what is euphemistically referred to as community engagement, which it's a work requirement, right? Understand what Senate Bill 1 does on the work requirement. The benefit design package. We have a proposed, this is not in the bill yet, we have a proposed Senate design package that that lowers the price for individuals if they get preventative care, which goes back to the general precept of the Healthy Indiana Plan, which, by the way, the original name for the Healthy Indiana Plan was the Indiana Checkup Plan, or ICUP. So we quickly moved away from the Indiana Checkup Plan. And it'll have health incentives and cost sharing. So hopefully that at least triggers some of your questions. Now, we fund that using the hospital assessment fee. And again, we've sent in our new hospital assessment fee, and we've asked for it to be grandfathered. We have not heard yet back from CMS. They may allow that. They may not allow that. That's an open question. We've also then, but we've chosen to use that our state-directed payment program. So when I say hospital assessment fee, read sources of cash. When I say state-directed payment, uses of cash. So the uses of cash, we came up with a plan that said, well, we want to incentivize hospitals to lower their commercial rate, and if they do, we'll pay them more in Medicaid. Hospitals weren't thrilled about that idea. They just wanted us to give them more money. The governor said, well, listen to them, see what they have to say. So a group of hospitals came together, and they put together a plan that did that the governor liked. And so we submitted that earlier this year, and we await the CMS's opining on our state-directed payments program. Now let's come back to the budget, which unfortunately, it always comes back to the budget. It would be nice someday if that weren't the case, but I probably wouldn't be giving the presentation. So what you see here is the growth rate, and you've seen this slide before if you've been here, been with us very long. That's a 9.5% compounded average growth rate to get to 134% in general revenue fund over that period of time. So this is an unsustainable number. I think we all know that. I think you all knew that that this is what Governor Braun hired me to do, right? To make Medicaid boring again. And thanks to the folks in this room, we're on that path. So this is the this is the forecast that we used in April. And it should be 25. And what we had, well, the original forecast, right? We were I'm not sure this is the right slide, but regardless of that, I think the numbers are right here. We're saving $314 million this year in general fund revenue and $151 million next year, over and above that in general fund revenue, right? And that, though, starts to become the challenge for 28 and 29, right? And so for the first time, FSSA put out budget numbers or forecast numbers that looked into the next biennium. And we'll continue to do that. It is my goal to get out 2 bienniums, because changes we make today in the Indiana Medicaid program we don't really see the fiscal effect for 18 to 24 months. So we've got to be looking out that far to make sure that we're not, that big ship that you see doesn't in fact turn into what you all think it is, which is the Titanic. And so we're back to this slide, right? We're back to this slide. We think we have a path. We think we have a path to get to there with your help. But that's not, the ship doesn't come into port, right? We really need your help in the out years to take that curve and maintain it at 2% rather than at 4% or more. So thank you very much for enduring today. It's a long day. Hopefully you learned a lot. And I'm happy to answer questions if there are any in the audience. Marcus will run around if he likes you and let you talk.
Raise your hand high so I can see it. This is amazing. Okay. Thank you all for coming.